Good afternoon. My name is Walter Leal. I'm a faculty here at the University of California, Davis. We are starting now the COVID-19 Symposium to answer your questions. For questions, people watching via YouTube, please send via chat. People on Zoom, send via chat to panelists and all attendees, because we are monitored outside of the panel. Therefore, if you ask the question only to the panelists, we're not going to be able to see. Undoubtedly, COVID-19 is a pandemic of our generation, a pandemic of the 21st century. Here are the numbers of cases until 6 o'clock this morning, with more than 185,000 deaths. However, if you check the data, 6 hours later, we have an additional 3,500 deaths and 40,000 cases more. In the United States alone, we have 47,000 deaths in the morning, and now we have an addition of 1,400 deaths. Here at Yolo County, this is the latest data. We have a total of 105 cases with 12 deaths in this county. By the way, the patient number 1 from Yolo County is going to be joining us also in this event. We're going to have a combination of presentations, short presentations, and the questions and answers. We received lots of questions from the audience already before doing the registration. And we are going also to entertain questions through the chat. So the program for today, we are going to start very soon with the welcome remark by Chancellor May. Then Professor Emmanuel Maverax, as a professor of dermatology and immunology of the University of California, Davis in the medical school. And then we have also the participation of Dr. Stuart Cohen, the medical doctor in charge of the trials with Redemcir and the other compounds that are being tried as a cure for this disease. He'll be joined later because right now he's quite busy. Unfortunately, Dr. Ron Chapman, the health officer from the Yolo County, at last minute have to withdraw his participation. Dr. Nathan Cooperman, he's in charge of emergency at the University of California Hospital in Sacramento, and he has very important information to share with us today. He's here with us. Dr. Nicole Baumgart, she's a professor in the Department of Pathology, Microbiology, and Immunology of the School of Veterinary Medicine. And last but not least, Dr. Richard Pan, who is also a state senator. And so he shared the knowledge of the medical profession as well as a community leader. We have also some other participants that have not been announced before. Like I mentioned in passing, Dr. Marilyn Stebbins, the patient number 1 in the Yolo County, she's going to be here with us. Dr. Yu Lo Hichi, she's a distinguished professor from the University of California, Davis, specialized in textile and clothing. And she's going to answer a question about masks and things like that. Dr. Michael Oldstone from Scripps Research, he's an immunologist and also a historian, and he has very interesting perspective to share with us today. Professor Jimmy Carey from the Department of Entomology is a distinguished professor at the University of California, Davis. He's also a demographer, and he has some interesting perspective to share. Dr. Niels Pedersen from the University of California, Davis, from the vet school, distinguished professor emeritus. He has been working with coronavirus in cats. And now the news is that also the coronavirus that affect humans are also being affect cats. As of last night, CDC reported 2 cases. So he's going to be with us. And also Dr. Annie Willie, she's from Yale University. And yesterday they published a preprint where they show that one can collect the samples for tests with the coronavirus directly from the saliva. So this is very important. It was last night that they reported the paper, and we are able to contact her and to have her on a video that we're going to share with you today. This is going to be, this is being broadcasted in YouTube and via Zoom. We have 504 participants right now in Zoom, and more are coming in, and 242 people following us on YouTube. So YouTube has a 20-second delay, be aware of that. So if you watch the news are going to have a delay. We have a room for 400 people in Zoom. Yet before we start, we had more than 700 people already registered. I think Zoom gave us a pass this time because such an important issue. Without further ado, I would like to turn over now the floor to Chancellor Gary May. Dr. May is the UC Davis 7th Chancellor. He's a recipient of the 2015 Presidential Award for Excellence in STEM Mentoring, and is also a member of the National Academy of Engineers. Chancellor May, the floor is yours.
Thank you, Professor Lel. So on behalf of UC Davis, I'd like to welcome you to our COVID-19 Public Awareness Symposium. I hope that you and your loved ones are staying healthy and comfortable while we're all sheltering in place. First, I'd like to thank Professor Lil for bringing us all here together. He's assembled a distinguished panel of speakers, and they are ready to provide us with answers to our questions. They range from UC Davis experts in infectious disease and emergency medicine to public health officers and elected officials. And I thank them all for being here and lending their expertise. We all have questions about how we can best protect ourselves from COVID-19. We want to know how well our healthcare system is prepared and what progress we're making in the fight against COVID-19. Perhaps more than anything, we want to know when our daily life might start returning to normal and what steps might help get us there. I'm proud of the leadership and the innovation that UC Davis has shown through this public health crisis. Our region is fortunate to have a leading research university with a medical center, and this allows us to advance the UC Davis mission in critical ways. UC Davis Health has made national headlines back in February after treating the very first case of COVID-19 that was acquired through community spread. That patient was treated at the UC Davis Medical Center and has since recovered. UC Davis Health was instrumental in prompting the Centers for Disease Control to change testing protocols and published an index study of that first patient. Since then, UC Davis Health has several clinical trials underway, which you'll hear about today. We have researchers from a wide variety of disciplines collaborating. Our schools of medicine, veterinary medicine, and the Center for Immunology and Infectious Diseases are working together to seek breakthroughs in vaccines and diagnostic testing. Our College of Engineering is working with the School of Medicine researchers on technological innovations for producing ventilators and 3D printed test swabs. We have communications experts analyzing millions of social media posts to identify emerging outbreaks. Our School of Medicine and Office of Research are also hosting a series of COVID-19 research virtual town hall meetings. The reception for this has been incredible. Within the minute of launching the very first Zoom meeting of the town halls, attendance hit the Zoom capacity of 300. So these are just a few examples of how UC Davis is driven to be a part of the COVID-19 solution. In the meantime, UC Davis is rising to the challenges while adapting to public safety measures. We remain committed to safety and well-being of our community. Back in February, we had a suspected case in one of our residence halls, and we worked quickly with public health officials to isolate 2 students as another student was being tested. Our UC Davis campus moved to a state of suspended operations in March, a significant transition for us. Our faculty and students are adjusting to remote instruction currently, and we're learning how to successfully host events and conduct campus functions and classes in the virtual realm. For students who remain on campus, we are urging them to follow social distancing guidelines and heed recommendations for preventive care. We are also providing students with a variety of resources to benefit their mental and physical health. We've had to make some tough decisions during this crisis, such as canceling our traditional picnic day a week or so ago and postponing spring graduation ceremonies. I can definitely relate to the disappointment of our students for the latter. My youngest daughter's college graduation was also postponed indefinitely because of the crisis. We've done our best to listen to students and survey their preferences. Now we're moving toward a virtual commencement in June and exploring the possibilities of holding an in-person ceremony later in the year, perhaps toward year's end. I'm proud that UC Davis continues to show resilience. Our students and staff are stepping up to help one another, volunteering at food banks and finding creative ways to stay connected. And of course, we owe tremendous gratitude to healthcare workers at UC Davis and beyond. Their commitment to patient care and public health in a time of pandemic is nothing short of heroic. So I remain optimistic that we'll get through this crisis together. UC Davis remains determined to serve the public good, and this symposium is one example of our efforts. I appreciate your participation today, and I wish good health and safety to all of you. Before I conclude, Professor Lell has asked me to address some of the questions that came through prior to the beginning of the symposium. I won't have time to address all of the questions in detail, but I'll sort of bucket them in three areas. They regard the current state of the campus, the near term future state, and the further out future state. And for the near term, well, let me just say first, all of our decisions that we make are guided first and foremost by the safety and health of our students, our staff, our faculty, and our surrounding community. And in addition to that, we obviously will comply with any guidance or recommendations or restrictions that are handed down by the county or state public health officials. Now, as far as our current state, the campus is currently housing approximately fewer than 600 students in the dormitories. That's down significantly from what would normally be more than 7,000 students. These students, due to the lower density, we are fortunate to be able to house the students in single rooms, and that enables us to isolate them appropriately when necessary.
I think you lost your audio.
Do you want me to just go, Walter?
Yeah, no, let me do that. Okay, so, all right, so let's move on, and then the Chancellor comes back later on and continues with his statement. So let me introduce the first medical doctor that will be with us today.
We will have approximately four phases, I should say, and those phases will be current state through research that has time sensitivity, to research activities that address the restart of activities, and finally up to full speed operations. And we hope to have, I don't have a timetable for that because our timetable will be guided by our constraints that we're given by what the county and the state allow us to do. And finally, there were many questions about what will happen in the fall. A lot of that is unknown and uncertain at this point. We have two working groups working on both what will happen in terms of our academic enterprise and the second working group on our operations. We suspect that there will be some limitations placed on housing of students in the dormitories, as well as large gatherings and large classroom activities. So we are still waiting to hear from the state on those restrictions, and we'll of course abide by whatever the state recommends. And I'm going to conclude there. And again, thank you for participating, and everyone, please stay safe and have an enjoyable symposium. Thank you.
Thank you, Chancellor May, for your welcome remarks and answer some of the questions that it came to us. And let's move on now with the first speaker of the day, Dr. Manuel Maverax. He's a professor of dermatology and immunology of the University of California, Davis Medical School. He's a leading physician scientist with experience in conducting cutting-edge basic science in the clinical research. He's a PK's recipient. One might ask what that means. As a Presidential Early Career Award for Scientists and Engineers. He's a NIH Director New Investigator Award recipient. And he graduated from Harvard in 2003 with a medical doctor degree, summa cum laude. And he's only one of the 15 students in the short history of Harvard that graduate with that honor. So Professor Maverax, the floor is yours. Let me stop
Thank you.
sharing here and do.
I'm going to try to, there we go. So one of the questions I've been receiving from the group and from my colleagues and people I run into is, could we have prevented this? And I think today I'm going to talk to you about ways to prevent the spread of COVID-19, but let's take a quick step back and see how we got here today and what we could have done that would have prevented this pandemic. So as it turns out that, okay, there we go. Okay, so it turns out that most countries did not have an effective COVID-19 plan. So the US is not alone in that regard, but Taiwan was able to prevent the virus from entering its country. So Taiwan is part of China, but it also has its own separate government. And millions of people in Taiwan work in China, and millions of people from China come and visit Taiwan. So it's closely integrated with the mainland China. But for some reason, they were able to keep COVID-19 basically out of their country, or prevent its spread once it entered the country. So they have very, very few cases. To go back and how this happened is one of the things they did right was they started very early. So at the time when we didn't even know about COVID, that we didn't have a name for the virus, we knew that there was an outbreak in Wuhan, China. Back in December, Taiwan had already had people on the ground, and when planes arrived from Wuhan, China, they put officials on them to make sure that the people did not have fever or pneumonia symptoms before they came into their country. Whereas in the US, we had our eyes on the virus, but we weren't making any type of statements to the public yet. The CDC was just like, Happy New Year, and nothing at all to do with coronavirus. However, a couple weeks later, the US caught on, and we were also screening travelers arriving from Wuhan, China. But we also did a couple of things that I think were unfortunate. So the CDC kind of downplayed the risk to Americans throughout the whole beginning of the crisis, starting from things like saying that there's limited person-to-person spread in Asia, risk to the American public remains low. And of course, we know that there wasn't limited person-to-person spread in Asia at the time. At the same time, Taiwan really started ramping up their measures to protect their citizens from this virus. So they set the price for masks. They didn't allow market to set the price. They said, this is how much our public is going to pay for masks. And then they started working on manufacturing of masks in Taiwan. They had really aggressive quarantining procedures, and they used electronic monitoring of the people that they were quarantined. So they just didn't send people to quarantine and believe them that they stayed quarantined. They were actually monitoring the people while they were in quarantine. January 30th, we in the US, we announced our first person-to-person spread. And then we start quarantining people too. On January 31st, we quarantined 195 people, but these were people who are coming back from the Wuhan area of China, so that there was some reason to quarantine them. But we weren't quarantining as they were doing in Taiwan. So January 30th, Taiwan is now really upping the production of masks, and then they're setting aside how many masks go into the hospitals and how many masks go to the general public. So they would put 1.4 million masks to the hospitals, 2.6 million masks to the general public, and that was each day. And they would set the price for the mask. So at this time, they set the price at 27 cents per mask, and they set really aggressive penalties. So if you start hoarding masks, if you start upping the price, you could be served as many as 7 years in prison for that and pay $167,000 US fine. There were numerous travel bans. So we had pretty good travel bans too, but Taiwan really went aggressive with their travel bans, and they went very aggressive with their quarantining enforcements. They continued to upgrade the mask production. They started licensing companies to disinfect public spaces, and they set national standard guidelines for cleaning. They mobilized the soldiers into the manufacturing plants. So they put their soldiers in to start making masks. They dropped the price of the mask to 17 cents a day. They had, again, lots of anti-hoarding laws. They started, the government started taking the responsibility of distributing the masks. And then at this time, they really increased the amount of COVID testing that they were doing, and they increased their capacity for COVID testing in February. So basically, everybody is wearing masks in Taiwan. There's aggressive quarantining, and they're doing lots of COVID testing. So in the US, we took a little bit different approach. The CDC said that we're going to do things that have proven effective public health measures, things that have already been proven. And we'll go into some of this data in a little bit. So it turns out that not everything is very clear in these pandemics, and we really don't have good data. The CDC also de-emphasized the ability of this virus to spread from people who are not actively sick. And this is something that went directly against what they were doing in Taiwan and in China, where they're advertising that normal people could spread this virus that don't seem to be sick. The CDC at this time was saying that spread was mainly among close contacts. People that are most contagious are the ones that are most symptomatic. Of course, this is true, but I think the most, one of the problems with this virus is that people who are not actively sick could still be spreading the virus. And there is good data that this could be happening in China, but we weren't emphasizing that at this time. And it took us a very long time to admit that, actually. February 18th, they're saying, I know Americans are concerned. This is what the CDC is saying. I know Americans are maybe concerned, but all the cases in the United States are in people who have traveled to China or their close contacts. They were saying that the risk to the general public was still low. And then February 25th, they did a complete 180, and now they're saying that the virus will cause a pandemic. It's not so much of a question of if this will happen anymore, but rather a question of when and how many. And they're really referring to people in the US, that US people are going to start getting sick, and how many is the question, not if this is going to happen. February 29th, we have our first COVID death, the CDC reports. And February 29th, now we're having community spread all over the place, California, Oregon, and Washington. And although in the center of all of this community spread, the CDC is now saying that most people in the US have little immediate risk. CDC in March, throughout this whole time, I don't put up lots of slides, but throughout this whole time, the CDC is emphasizing not to use masks. So March 6th, they're saying masks are not recommended for people who are well. Again, in Taiwan, everybody's wearing masks. Kids are wearing masks. You know, little tiny children are wearing masks. March 15th, the CDC starts talking about social distancing. Now, the CDC has always had a social distancing, has always talked about social distancing, but they weren't advertising social distancing until mid-March. This was followed by April. It went from let's stop the spread of the virus to basically let's prevent the hospitals from being overrun. And the hospitals in some areas like New York have definitely been overrun. So April 1st is when we start talking about flattening the curve. It's very important to flatten the curve so the hospitals don't get overrun. This is the message from the CDC. Finally, on April 1st, now the CDC is advertising to people that people without symptoms are spreading the illness. And that is very different from what they're saying on February 14th. So from February 14th to April 1st, the message is now strongly changing. And finally, on April 3rd, the CDC recommends use of cloth coverings. So basically masks, we're allowed to wear them on April 3rd. But it's not like such a hammered message that everybody is wearing masks. When I go outside, most people are still, I would say maybe 50% at best are wearing masks. And this is one of the measures that kept Taiwan safe. We still haven't been able to implement it in the US yet. So what do we do now? We see the mistakes we made, but what can we do now to protect ourselves? Well, the CDC says it's focused on the prevention of the spread of the virus through proven effective health measures. But what does the data show? So this is the CDC hand hygiene strategy, which I don't agree with. It says clean your hands often, scrub them for 20 seconds, rinse and dry, and only use alcohol-based hand sanitizers if soap and water are not readily available, and don't touch your face. So what does the data show? Because the CDC says they're going by proven effective health measures. Well, there's been, as you can imagine, it's very difficult to find out if hand washing actually helps. We know the virus is on our hands. We know that we auto-inoculate ourselves. So it's it's intuitive to think that if we wash our hands, that we will not be able to auto-inoculate ourselves and the spread of virus will go down. And before I go into too much more of this, of course, I'm recommending hand hygiene policy, but our policy that I'm recommending is different from what the CDC is saying. So according to this meta-analysis, in the medical literature, what some people do sometimes is they'll do a meta-analysis. That means they'll combine all the studies that have been published to try to get a more accurate prediction of how much something helps. And this very nicely conducted a meta-analysis for influenza, not COVID-19, but for influenza. The conclusion was that the combination of hand hygiene with face masks is effective, but hand hygiene alone is not effective. This is another very nicely done meta-analysis. And this meta-analysis said that hand hygiene measures were effective, but they're not very strongly effective. And in this analysis, they had there was something called residual heterogeneity, which was significant, which means that what this means is that this data is not highly reliable because there's still a lot of residual heterogeneity. So from this, we conclude that data does not strongly support hand washing alone, that we have to use it in conjunction with other things. But what's the problem with hand washing? Because obviously when you wash your hands, you can remove viral particles from your hands and you shouldn't be auto-inoculating yourself from that. Well, the problem is that we're implementing suboptimal hand hygiene strategies. And this is important because if you're going by published data that's proven, then you're limited to what your policy is. And if there's no proven data that something works, then basically you have no policy. So right now, we have this hand washing policy and it's not really proven that this is the best way to protect ourselves. So in these types of scenarios, we don't abandon hand hygiene because of course it's one of the most important things we could do, but we shouldn't just be accepting how we always been doing it. We should have a revised hand hygiene protocol to try to improve upon the strategies that to date haven't been highly effective. So again, the CDC says scrub your hands for at least 20 seconds. They said you can use alcohol-based hand sanitizer only if soap and water are not readily available, and don't touch your face. So what's the problem with this? Well, the problem with this is that the emphasis is on being thorough, and that sometimes is not the best way to go about implementing a strategy. For example, instead of putting an emphasis on being thorough, a more effective strategy may be from putting an emphasis on feasibility, tolerability, and frequency. So if you could do something that's very thorough, but it's not feasible, nobody's gonna do it. And if you implement something that's really great, but people can't tolerate it, it's not gonna work either. And in terms of hand hygiene, these are my personal beliefs. I don't have any published data on this. My personal belief is that feasibility, tolerability, and most importantly, frequency are the most important things. So what do I mean by this? Where our hands are not designed for frequent hand washing. Washing our hands damages our skin barrier, and 15% of the US population has a genetic defect in their skin barrier. That means that these people cannot tolerate excessive hand washing. They're genetically deficient in their ability to wash their hands because their skin barrier can't tolerate those 20 seconds of scrubbing. So even in people with normal skin barrier, we could only, if we're really gonna scrub them with soap and water for 20 seconds a day, we could really only tolerate that about 10 times a day until our skin barrier breaks down over time. And once our skin barrier breaks down, it takes 30 whole days for it to regenerate itself. So we're in a lot of trouble for those 30 days. So what can we do? And this is, I don't mean to scare anybody because I want you to wash your hands. but this is what happens when you wash them too much. So how do we come up with a hand strategy that's a hand hygiene strategy that's feasible, tolerable, and that we could do it all the time? Well, one thing is that alcohol-based hand sanitizers can be used up to 100 times a day in somebody with normal skin barrier function. So these are damaging to our skin barrier, but not nearly as damaging as soap and water. So we could really up the amount of times people are engaged in hand hygiene practices if we allow them to use alcohol-based hand sanitizers as frequently as they can. Alcohol-based hand sanitizers can be applied thoroughly in just 6 seconds, whereas like to find a sink, you have to go through all these contaminated surfaces to get to the sink. Like if you go in the bathroom in a gas station, you have to get through that door, and the sink itself looks gross, and then you got to wash your hands in that sink and somehow get out of that bathroom without contaminating yourself. And the amount of time you have to wash your hands is just not as feasible as doing hand sanitization. So instead of alcohol-based hand sanitizers, only if soap and water is not available, I think the CDC should adopt a balanced approach. That's not to give up washing your hands, but we need a balanced approach. So this would mean that, well, in this approach, the goal would be to maximize the frequency and to maximize the implementation of the strategy. So we recognize that hand washing tolerance is highly variable. So some people could do it a lot, some people could wash their hands a lot, some people can't. So we have to recognize that in our policy and have it individualized to each person. Tell them that they should wash their hands to their own tolerance. This may be 10 times a day, this may be twice a day, but the emphasis should be placed on washing your hands after contact with contaminated surfaces and when your hands are soiled. So if you have dirt on your hands, obviously you have to wash them. If you think you touched something that you saw somebody coughing on, or you like go in the grocery store and you touch something that you see tons of people touching, well then of course hand washing would be a good time. That would be a good time to waste one of your hand washing tickets for the day, because you only have so many hand washing tickets you could use in a day. And then in addition to those hand washings, we need to maximize the amount of time people are using the alcohol-based hand sanitizers. So they should basically be using alcohol-based hand sanitizers as frequently as possible, just assuming that everything is contaminated. And this is on top of their hand washing, their individual hand washing tolerance. We recommend wearable hand sanitizer, because you don't want your hand sanitizer inside your purse, because then you can imagine that you got to open your purse. So you think your hands are contaminated, you have to open your purse, you have to go inside your purse, and now you're contaminating other surfaces. So we recommend wearable hand sanitizers. They make a little cute hand sanitizer, or any type of container that you can put hand sanitizer in. You wear this on the outside of your garment, you don't put it inside your purse. Then it's a constant reminder that you should be sanitizing your hands, with the goal again to sanitize your hands as frequently as possible throughout the day. And then last thing, I just want to mention this don't touch your face policy that the CDC has. I've been watching we have little photos of video of the different speakers. I've been watching to see if any of them are touching their hands. You can see that Dr. Liao just touched his face with his hands with his face, but interestingly, Dr. Pan has not touched his face the entire time for these 15 minutes. So he must have crazy good skills. But for the general public, we don't realize that we're touching our face, but it's very difficult to touch our face. I think there should be a lot of education that we are auto-inoculating ourselves by spreading virus from the surfaces we touch to our face, and we should educate people in that, so that to encourage them to sanitize their hands as frequently as possible. But telling people not to touch their face is basically impossible. I deal with patients all the time who actually have problems, different types of diseases that are related to touching their face too much, and it's very difficult to get them to stop. And the reason why is the reason why it's impossible not to touch your face is because this is our sensory homunculus. You could see that a vast amount of our sensory cortex is dedicated to sensation of the face and sensation of the hand. So these things are just like layered on top of each other. It's impossible not to bring your hand up to your face. you just have too much sensation. And you do it not knowingly, like you don't know that you're doing it. It just happens throughout the day. So I think this is one of the reasons why we have to sanitize our hands all the time, but we shouldn't be wasting a lot of public education on telling people not to touch their face. I'm gonna stop there. I really appreciate you guys listening to me and everybody tuned in for that long talk.
Thank you, Dr. Maveraxis. Thank you, Manuel, for this very nice introduction of the problem. We're going to move on now and moving down to the next speaker that's going to do also some introductory remarks. Nicole Baumgart. She's a professor in PMI, that's the Pathology and Microbiology and Immunology of the School of Veterinary Medicine. She has clinical training in veterinary medicine and basic training in microbiology and immunology. She's an immunologist who studies host pathogen interaction with research emphasis on influenza virus. Influenza virus is also another RNA virus like the coronavirus. She also worked with Lyme diseases, and she used mouse as the model of infection. The focus of her research is on the induction and the regulation of antibody generation after infections and the ways in which they provide immunoprotection, so that that information is used to inform better vaccine design. Nicole, thank you for being here. And I turn the floor now to you, and I'll stop sharing.
Yeah, thank you. If you could switch off screen sharing, because I can't activate without Emmanuel.
Yeah, we can now.
Am I screwing things up, or are we okay?
Yeah, could you stop sharing screen? So I can start.
You are allowed now.
Okay, thank you. All right, so I'm going to talk briefly about what this new SARS coronavirus 2 is and where it came from. How does the virus infect host cells? So how it actually gets into patients. And then what role the immune system plays in helping us overcome the infection, and where the immune system might actually go wrong and enhance disease. And just, I will use the term SARS-CoV-2 or COVID-2, and SARS, of course, stands for Severe Acute Respiratory Syndrome, a term that was coined in 2002, 2003, when the first coronavirus that caused a very similar disease emerged. So here is, and I won't go into many more details, but there are hundreds, if not thousands, of different coronaviruses. Only a handful are known to infect humans. And you will hear a little more about that later, so I won't talk about this anymore. But I want to just give you an overview of the structure that I think everybody has seen in one form or another by now. And point out what from the immune system's point of view, what this virus looks like. Very important are these so-called spike proteins. These are the parts of the virus that help the virus attach to a cell and allows them to dog on, if you will, and then infect. And then the other part of that the immune system responds to is actually inside this enveloped virus, and that is the nuclear protein. That is a protein which around the nucleic acid material, the genetic code of the virus is actually wrapped around NP or nuclear protein. What is important is that if you want to stop a virus from entering a cell, you have to deal with these proteins that are on the surface of the cell to actually block it. Whereas you can have good immune responses to the internal parts of the virus, they may be helpful, but they could not prevent you from getting infected. And I want to also point out that viruses are not alive. Viruses cannot live unless they take over a cell. And so basically what you have is you have genetic material wrapped around some proteins. And it's actually quite shocking that something this small and without the ability itself to live can cause so much damage. So here is the handful of viruses listed that have been identified to cause human disease. And in most cases, the disease is a mild upper respiratory tract infection. In most cases, never diagnosed. We get a sniffle and we don't really know exactly which virus it is. But these two viruses really have given us a clue of what we now know actually the outcome is. And they were sort of the first signs that there are coronaviruses that could actually cause much more serious disease. The first one was this severe acute respiratory syndrome virus, this original SARS virus. In 2002, there was an outbreak in Asia that led to a few thousand infections and actually nearly 800 deaths, which was a rate of about 30%, 34%, which of course is a shocking rate if you consider how many people are infected worldwide today, which is 2.5 million. Imagine if 1/3 of them would actually die. So this virus was contained through public health measures, and probably also this virus was not as good as infecting humans, and that was because it didn't seem to spread from human to human. In contrast to the coronavirus outbreak that we're dealing right now, where a lot of people seem to be shedding the virus and able to infect other people without even having any signs of disease yet. This virus seemed to not be able to be transmitted until actually symptoms were seen. And therefore it was easier to contain this virus. Like the current corona, and then there's a second one, the Middle Eastern respiratory syndrome virus, which very similarly causes small outbreaks, relatively small outbreaks, and it's because it is not so efficiently transmitted, has never expanded over the whole globe and caused a pandemic. All of these viruses have in common not only that they're coronaviruses, but also that they have very close cousins and probably originated from bats that are living in Asia. And in these two cases of these severe coronavirus-induced diseases, these viruses had an intermediary host. In case of the original SARS virus, it was the civet cat. And in case of the MERS coronavirus, it's actually a dromedar. We don't know whether the new coronavirus has an intermediary host. That has not been determined. Where did it come from? As you already heard, the horseshoe bat is highly implemented and probably the likely original source of the coronavirus. And I will show you this on the next slide a little more. There was also the suggestion that maybe the pangolin, which is shown here, might actually also be the origin of this virus. So this is a slide that was kindly made available to me by Tracy Goldstein, who actually is a coronavirus expert and works at the One Health Institute here at UC Davis. And what this group of investigators has done is has gone into caves, bat caves, and has actually sampled virus material from bats and has sequenced them. And when you take all the sequences that were obtained, they identified hundreds of different coronaviruses. Virtually none have ever been seen in humans. But given the history of the SARS and also the MERS, of course, there's always the danger of the spillover. And here is the new SARS coronavirus that just emerged last year. And what you can see, and so the way to read this is a list of different sequences, and the shorter the line is, the more closely related two viruses are to each other. And the more distantly related these viruses are, the longer the line is. And what you can see here is that there are two other coronaviruses that are very closely related. There's this one here, which the new coronavirus shares an ancestor with. And this is identified in the horseshoe bat. And this is why people believe that it's likely that these viruses emerged from the bat, because of this very close genetic identity. And then the Pangolin coronavirus, as you can see here, has a little bit less of a direct correlation. They had a common ancestor virus here, but it separated probably a little earlier. So based on this genetic analysis, the idea is that the virus very likely emerged from a virus that was found in bats. And so this is a paper that was published in PNAS last week, a very respected scientific journal, where they used this bat sequence and compared that sequence to 160 other sequences of this new SARS-CoV-2 virus that has been isolated from individual patients that got sick. And so this bat virus has 96.2% sequence homology. So all but 3.8% of the genetic material between this virus and bats and any of the viruses isolated in humans is identical. And that is a very high degree of homology and suggests, although it doesn't prove in any way, that this virus is indeed the virus that is the ancestor of the virus that gave rise to the infection. And so if you look at this, what happened is that at some point in time, the first case in Wuhan was identified in China. And this virus infected a number of individuals that we know of, including in blue here, an American who had traveled to China to visit family and then returned to the United States. But as you can see here, this is virus actually, and so the size of the dot is sort of the number of individuals that got infected with that exact virus. As you can see, this virus did not cause the biggest outbreak. What happened is that this virus stayed pretty much in China unless they were travelers. But it underwent a mutation that changed one amino acid, one building block of protein. And once it had this one change, now the virus started spreading within Wuhan, within the city, and it infected many different individuals in China as well as other parts of Southeast Asia and caused this massive outbreak. And for reasons we don't yet understand, this virus, however, seemed to, although spreading very widely in Southeast Asia, it was not really able to get a foothold in Europe or in the US, and that is certainly not because there was no traffic and no chances. There was some bottleneck that I think future research will identify why that was. But an additional mutation occurred in this virus with one more change in one more amino acid. And that virus now, which is sort of labeled here C, that virus spread through and caused the outbreaks in Germany, Italy, and also in the US. So this is how we understand the virus emerged from. Again, this is all based on changes in the genetic material and the information we have. So, so the virus, and you have seen a picture like this, and you're thinking about this every day as you're putting on your mask. The idea is that the virus infects humans by basically the human coughing or sneezing or breathing very heavily or speaking. Even speech might be enough to create an aerosol that you can take up either through mouth or nose. And distance, of course, makes a difference. And the further away you are to another human, this is our 6-foot rule that we have in place right now, that is enough to prevent the infection. The virus then enters the upper respiratory tract. And in 80% or so of cases that we know of, the virus replicates in the nose and maybe in the throat. And then the immune system takes over and clears this virus, and that then causes the very mild disease that is clearly seen. But the virus replicates in these tissues, and it's this why even people that have no symptoms or maybe very mild symptoms that would be not distinguishable from having maybe allergies or something can already maybe infect, because the virus is right here where speaking or sneezing or coughing would spread the virus. In thankfully, relatively rare instances, the immune system cannot control the virus replication in the upper respiratory tract. And now the virus makes its way down the airways into the lower parts of the lung. And it is here when the virus enters the lung and replicates here in this tissue that actually disease becomes prevalent. And I will talk about this in a minute. So let's think about how the virus actually enters the cell, because without the cell, the virus cannot replicate. So as I already mentioned, these spike proteins are the most important parts for SARS to get into the cell. So, and the spike protein binds to this receptor on the surface of cells in the respiratory tract called ACE2. And this receptor is the same between the SARS coronavirus and the new SARS-CoV-2. It's the same receptor. And this receptor allows the virus to dock on. And then a second receptor, which is a protease, an enzyme that can lead to proteolytic cleavage, actually activates further this interaction and allows the virus now not only to hang on, but actually to enter the cell, a process called fusion. And interestingly, we actually have already we have an FDA-approved drug that can actually prevent this protease from doing its function. Unfortunately, there may be other proteases that can take over. So what is very interesting also is the close relationship between the original SARS virus that emerged in 2002 and the virus here has been shown in a recent study that antibodies that can prevent infection with the SARS coronavirus have some efficacy also in preventing infection with COVID-2. Fortunately, of course, the virus didn't spread very much, so very few people actually have, obviously, immunity to the original SARS virus. Here is just the same process that I showed you, the docking on, and just to make the point that when the virus is entering the cell, it will actually destroy the cell eventually. The virus goes in, the cell becomes a virus replication machine and will actually break down. And so you have destruction of your epithelial cells in the respiratory tract. And that damage, that primary damage of the virus, makes you also susceptible for infection with bacteria that are always around us, but not usually infect us because they can't penetrate the surface of the respiratory tract. But once damaged by the virus, infection can occur. So let's talk about the immune system briefly. There are many different parts of the immune system that are at play and that are helping us to overcome and fight the infection. And in the majority of cases, the immune system does a good job in doing so. And I obviously don't have time to go through all the details, but I wanted to point out a few. A very early and usually very effective way of preventing us from cells from getting infected is the secretion of a what is called a cytokine, a hormone that is made by many cells in the body that alerts the neighboring cells that they have been infected with a virus. And the secretion of that cytokine, type 1 interferon, will protect another cell from being infected. Many viruses, and coronavirus is one of them, has found ways to inactivate this very early alert system. And that is thought to contribute to the spread of coronavirus. Although we have this system and it will eventually kick in, maybe the delay in having the cytokine being generated in large amount helps the virus to get a foothold. We have cells that can recognize infected host cells and can kill that infected host cell. So now you have cell death directly from the virus, but you also have cell death because your immune cells are destroying cells that are infected with the virus. We have cells that are called natural killer cells. We have cells called macrophages, and both of those are much more effective if they have seen the type 1 interferon signal. And so preventing type 1 interferon interferon may also make these cells not as active as one wants. Then parts of the adaptive immune system that take some time to develop. These are rapid processes, these are slower processes, and are also at play. And that takes about a week to 2 to develop. And here we make now cells that are very specific for COVID-2 that would be also destroying the cells, or we activate cells that can make antibodies. I'll talk about this at the end of my talk. So, of course, all of what I described right now are very good immune responses. So why are we looking at the immune system as maybe also contributing to disease? The lung is a very special tissue, and in contrast to most other organs, the lung does not tolerate an overactivation of the immune system very much. You have, because what is the lung doing? It's through breathing, you get oxygen into a patient, and then the oxygen will diffuse, and the capillary, the blood that flows by these immediately adjacent to the airways, the red blood cells will pick up the oxygen and allow the oxygen to provide oxygen to all the tissues on the body. And the same way CO2, so that we exhale, will be taken up. Now, this very intimate relationship between the blood vessel and the airways is disturbed every time you have an immune cell coming in. So here is the little air sacs at the end of the airways. And you can see that in an immune response, you have lots of cells, lots of white blood cells coming into the space. And now every time there's a blood cell in here, in between these two layers, you cannot have this oxygen exchange happening. And increased inflammation and increases in these cells will make breathing harder and harder. And this is what we see in patients. They just don't have the normal level of oxygen in their blood. So finally, I want to just say a thing about antibodies. So we know that antibodies are very effective against other coronaviruses, against influenza virus. They can stop the virus from getting in by binding to the spike protein. They take a few days to develop. And importantly, we can measure antibodies. There are two types. One comes up earlier, the IgM, and one comes up later, and that can be diagnostically very useful in deciding whether somebody may have just had the infection or may have had the infection a while ago where there may be IgG but no IgM. And so as the virus might be harder to detect because the infection occurred a while ago, the antibodies are basically imprinting our immune system and can be used to identify people that have had the virus infection a while ago. So, and antibodies are usually very good, but they can also be bad if they help the immune system to kill more cells. So finally, a reason of why the virus may actually cause this disease also is this receptor it uses, the ACE2. I don't have time to go through all the details, but the ACE2 is basically counterbalancing another protein called angiotensin 2. And this, when produced, and that is regularly produced, actually will reduce oxygen and the ability to breathe and actually enhance inflammation. ACE2 counteracts this by getting rid of this protein by changing it. And therefore, it will actually lead to vasodilation, more oxygen flow, more blood flow to the lung, more oxygen in the blood, and reduced inflammation. However, the virus uses this to dock on. So it is possible by having this docking on, the virus effectively eliminates the function of this ACE2, therefore giving us too much inflammation, and may also affect blood pressure in a way that we have seen in patients. So that's I have right now for today, for now. Thank you.
Thank you very much, Nicole. If you stop, share your presentation there, I will come back in here. and get ready for the next speaker. Just give me a second here, go through down to your presentation. Lots of questions coming, be patient. We have going to do our best here to answer all the questions. Our next speaker comes from the front line. He's in charge of the emergency at the UC Davis Hospital, Dr. Nathan Cooperman. He's a distinguished professor and chair of emergency medicine at UC Davis Medical School. He's a pediatric emergency medical doctor, physician and clinical epidemiologist, and a leader in emergency medical services for children, particularly in multi-center research. Dr. Cooperman has received more than $30 million in federal grants and contracts as a principal investigator over the past decade, and has published more than 235 peer-reviewed papers. He's a member of the National Academy of Medicine. He was elected in 2010. And one side note is that both parents are Brazilian, and both parents are scientists and chemists. Their father was a PChem professor from Caltech, and his mother, 9 years old now, she is a organic chemist. So he has a lot of information on chemistry as well as a lot of information in the front line. Without further ado, let me turn it over to Kate so that he can present his result now. Let me stop sharing here. Okay, you can share it there now.
Okay, great. Let's see. Can you see my screen now?
Yes.
Great. So thank you, Dr. Leal. It's really a pleasure and an honor to be on this panel with everyone. And I'm just going to show a few slides to give you all some insights into the preparation of the emergency department in anticipation of arrival of COVID patients a couple of months ago. Give you a couple of interesting observations about treatment, and then I'm happy to open for questions. I just have about 5 minutes of prepared stuff, knowing that there would be questions afterwards. So when we started hearing the stories of Wuhan and the clinical circumstances that were described, we realized that we were really in unprecedented circumstances. What was being described was nothing that we had really ever seen before. So the first things that we knew that we had to do is that for emergency providers to feel safe and ready to care for sick patients, we needed to prepare and also to be prepared with our own safety. So we were making sure that we had sufficient PPE. As you know, that term has become pretty popularized, but that's personal protective equipment, which is basically surgical masks and sometimes N95s. We needed to make sure that our vulnerable workers, so we have workers here, for example, with cancer, or who are spouses of people with cancer, or have chronic conditions, we need to make sure that they were not going to be caring for individuals who were at risk. We created what's called an ILI pod. ILI stands for influenza-like illness, because when this pandemic started, we were in the middle of influenza season, which is very complicated because many of the signs and symptoms of COVID-19 are similar to those with influenza-like illness. So to minimize the contamination of one patient to the other, we created a separate area outside of our emergency department to care for the non-sick patients with influenza-like illness. We also, these sort of circumstances make you realize some of the fundamental practices of medicine and of life that are really important. And communication is at the root of all that is good in life and in medicine. So we realized we need to communicate very regularly because changes were coming up very quickly. We did not have randomized trials to base our treatment. We needed to learn from each other and from others across the country and across the world. So in the emergency department, we started having 3 times a day huddles. That is, we would gather physicians, nurses, and whatnot to share information about current practices because they were changing on a daily basis. We also, because of our great ability to do simulation, we have big simulation laboratories here at UC Davis. We practice dealing with the most complicated the sickest COVID patients, for example, inserting a tube into their lung was called intubation, while in PAPRs. PAPRs are those space hoods that you see that are ventilated inside that don't prevent viral particles to enter. So on a daily basis, we practice with simulation. I started communicating 3 or 4 times a week regularly with the department with sort of bulleted emails, and we started having a weekly town hall in the emergency department via Zoom, mostly to communicate vital information, but partially also to offset the sort of loneliness that we're all feeling, but knowing that we had to work really closely as a team. And then we also were in close collaboration, working with, there was a command center in the hospital that was meeting twice daily, and of course with health system leadership. So just a few things about emergency medicine treatment of individuals with COVID-19. As I mentioned, being in a very evidence-based department, we're a big NIH-funded department, and we like to treat our patients based on the most recent evidence. There was not a lot of evidence based on randomized trials. So we were relying on communications with, we have friends in Italy, we have friends in China, we have friends in New York who are dealing with that surge before we were. So that allowed us to gather some information about what was working and what was not. We developed a process, and we all know that telehealth is for sure a big part of the future of healthcare, but we had to transition very quickly into telehealth. So in our emergency department, for what we call the walking well, individuals who were coming to the department, but who were well, they just were worried. We basically did a triage of those individuals and arranged for same-day telehealth visits so that they could be treated, but they would not be bringing in infections to the emergency department. For those that were a little bit more symptomatic with influenza-like illness, they were sent to that special pod that I mentioned already. But if they had influenza-like illness but were sick, that is, had vital signs that were abnormal, low oxygen levels in their blood, then they were brought into our emergency department directly into an isolated room in a pod. At this point, of course, everybody in the emergency department was always in surgical masks. Surgical masks are good for protecting against droplet contamination. And if you are doing an invasive procedure, such as intubation, that's when you would be in an N95 mask that protects you against airborne infections. So we were cohorting patients. So we have several rooms in our emergency department that are what we call reverse isolation. They have high laminar flow that helps remove particles from the air. So the sickest patients would go into those rooms just in case we would need to do an invasive procedure like intubation. And one thing that was really fascinating that we learned, and we were very fortunate in California for 2 reasons. First of all, we had enlightened governmental leadership, and we started distancing early. That was just a lifesaver for Californians and ourselves and our colleagues, because first of all, we spared a lot of death. Secondly, it bought us time to learn from others in New York and elsewhere that didn't have the same good fortune that we did. So early on in this pandemic, patients were present with unbelievably low oxygen levels, but they're not gasping for air. It's part of the pathophysiology that Nicole was describing, and we had never seen this before. And early patients would be intubated, that is, have a breathing tube put in their lungs, even though they're awake and alert, because their oxygen levels were really low. Well, we learned early on that patients that were intubated were at extremely high risk of mortality. In fact, the overall rate of mortality of intubated patients with COVID-19 is around 50%. But what we learned to do is we learned that if you just deliver high flow of oxygen without intubation, many patients did just fine. So we upgraded certainly the PPE for high-risk procedures. As I mentioned, when you'd have a patient like that, you would put on an N95. We brought the intensive care unit team to the emergency department early. This is a disease of tremendous collaboration between emergency physicians, intensive care physicians, anesthesiologists, etc. As I mentioned, we were not intubating early. And finally, we have patients on clinical trials of experimental therapies. Dr. Cohen hopefully will be here shortly to talk about those. If not, I can elaborate more if Dr. Cohen doesn't come. And this is just my final thoughts, final slide. These really are unprecedented circumstances. And because of the vascular events that are associated with the Nicole, that was a really nice presentation. Many organs are involved. Of course, most prominently the lung and low blood oxygen, but we see disturbances of the heart, kidneys, the brain, all due to blood vessels. And the typical presentation is for the first week, you're fighting what looks like a cold or a flu, and while the virus is in your upper airways, in your what we call the pharynx, your throat. And that's the vast majority of patients. They do fine and it stops there. But then if the virus proceeds down into your lungs, that's when we see this, what we call a cytokine storm, the storm of this inflammatory response that is normally protective for individuals, but it's a hyper response that participates in the destruction of normally healthy cells. So a couple of final comments would be, for the next year, this virus is not going away until we have an effective vaccine. Of course, we've been blessed by a very low prevalence in Sacramento. So we're not seeing the amount of ICU admissions and death, and we've not outstripped our supplies of ventilators or PPE, but it's going to be around. So we have to remain very vigilant, because if you are infected, there are these important risks. And I just want to reiterate, 80%, to our best knowledge, 80% of patients infected will have mild to very few to no symptoms. 15% will be sick and will need hospitalization, but not intensive care support, and 5% will be critically ill. And our best guess of mortality here in the United States, it's a little bit complicated because we don't know the true denominator because of the crisis, as we all know, of lack of testing, but it's somewhere in the order of probably 0.5 to 1% would be our best guess. Two comments that I want to make that are recommendations for you all. First of all, a reason to come to the emergency department is for shortness of breath, because we know that COVID-19 can give you a variety of symptoms and fever and muscle aches and whatnot. And for those, you should certainly contact your provider and ideally get a telehealth visit, etc. But the emergency department is always here, very safe place to come. And if you have shortness of breath in this course of this illness, by all means come in. And the other couple of things that are important is now influenza season is gone. So if you do have flu-like symptoms with fever, muscle aches, etc., it is more likely to be COVID than influenza, because influenza is no longer here. And the very last thing I want to say is that one of the collateral problems we've seen, and mostly because people have been fearful to come to the hospital and emergency department, thinking that they're worried that they're going to catch a COVID here. The ER and the health system are extremely safe place to be. We have a low prevalence of COVID. We practice extremely safe practices. Everybody is masked in the hospital, both patients, visitors, and all the healthcare personnel. We've enacted really high safety standards here. And what we're seeing, though, is people who delay presentation for any reason to the emergency department. That is, they have an urgent complaint, but they've been waiting at home because they're scared about this COVID-19 infection. Please do not delay your care. Come to the emergency department. We're here for you. It's a safe place to be treated. And with that, I just wish everyone to be safe and be well, and I'm happy to take any questions.
Okay, so we're going to go back to those questions. We have received lots of questions from different people, and we have here pre-submitted questions. Are going to give priority to those. We're receiving lots of interesting questions through the chat as well, and we hope to address most of them. One of the questions is, has California been successful in flattening the curve? Do you have any thoughts on what first step might need to be implemented in order to open California to return to normalcy? So for that, I ask Dr. Michael Oldstone from Scripted Research to tell us again a tale of the two cities, a very important story during the pandemic flu in 1918. Let's go. Oops.
So first of all, I'm delighted to have you here. I read your book, and so many people did, and I never expected that this book would be so timely in 2020. You predicted that something may come back. So
let me just interrupt you and say that for your information, that the revised part of that book will be coming out in the summer, which will also have a chapter on COVID-19.
That's great. I'm looking forward to see that book. In the old edition that I have with me here, you talk about the tale of the two cities. And recently, the Washington Post presented the case here and illustrated that as the importance of social distance, shelter in place, things like that, to flatten the curve. So can you explain the story of the two cities that you talk in the book?
I think if you start at the beginning, the first thing was you have a quarantine to prevent people from being close together. And what happened was that certain cities like Philadelphia didn't have a quarantine and had a big rally to sell at that time Liberty bonds because of the war. And they had an enormous outbreak of disease, so much so that they ran out of coffins, and ran out of burial sites, is going on partly in New York now, and they had to bury people from Philadelphia in pits. Other cities had quarantines like Detroit and St. Louis, for example. And then some cities kept the quarantine and then relaxed it, only to have a rebound. Now we know that if you're exposed to an infection and you make the appropriate immune response, you'd be immune to it. One of the problems is that the antibody response that gives you immunity is neutralizing antibody. And that's not made till at least in the earliest cases that I know of, about 4 weeks after infection, usually by 4 months. The other antibodies that are made early are not necessarily antibodies that are protective. They say that you've been exposed to the virus. It's likely that 4 months later you'll have a neutralizing antibody, but we don't know that. We don't know that. So relaxing any quotes that you said curve really is dependent on knowing what the immunity of the people who are in the area they relax the curve to. And so until you have information of how many people are immune, that's not going to work.
So again, to stress the point, this is the curve of the two cities, Philadelphia, very large peak because they start late, and St. Louis with a flat there. Looks like almost the situation with New York and California at the moment. And what happened is that St. Louis released that, lifted that measure prematurely. And the second wave came, and it was even worse than the first one. So that's a very important issue to keep into consideration. Now, another question is that, do you have any thoughts on what first step might need to be implemented in order to open California public school? So this is a question that Senator Penn might be able to help us with that. Let me introduce you, Senator Richard Penn. Like I said before, he's a medical doctor, a senator representing the 6th District, and he's the chair of the Senate Committee on Health. So he has a good hand on that. So let me open the floor to Senator Richard N. Senator.
Thank you, Dr. Lael, and again, appreciate you having me on this conference. I know that many of the presenters have actually focused more on the micro, the disease itself. I'm going to be talking about the macro. As you said, the question was about lifting for schools. And I just want to first begin by saying that as a member of the California State Senate, as chair of the Health Committee, we actually had a hearing last March, talking about our public health preparedness for an outbreak. So the idea that having some form of a pandemic is something that we did not project would happen. Now, certainly we did not predict this particular pandemic being at this particular time, but knowing that we had to prepare in the future is certainly something that was on the radar screen for the California State Senate. And I was proud to chair that hearing. I would also point out that today here in California, or at least as of reported on April 21st, we have had in California approximately 1,354 deaths. The reason I say approximately is because many scientists who have been looking at these numbers have estimated that we actually are underreporting the number of deaths from COVID. So when we look at the number of deaths coming from COVID-19 and you look at excess deaths, make note that because we only count the ones in which the person is actually tested positive and has a plausible mechanism, we are probably undercounting the number of deaths related to COVID. In fact, most recently in the news, the pathologists identified 2 people who are actually probably died of COVID, who were not counted originally, who probably got COVID early on in early February. The other thing I would point out is, in addition, is that we took early action here in the state of California. In fact, a UCSF scientist estimated that because of the actions we took, we probably saved somewhere between 30 to 40,000 lives here in California because we took that early action. And talking about the tale of 2 cities, to contrast with New York, New York basically implemented a stay-at-home order about a week after we did in California, simply about a week later. And the contrast is clear. You think about New York City with over 11,000 deaths compared with the entire state of California, as I've just told you, tells you the significant difference that happened. The other thing I also mentioned is that there's a lot of conversation about herd immunity or community immunity. And some people claiming that, well, actually, we can just lift the orders because, after all, there are people who've perhaps gotten the disease that we have not counted, and we certainly understand that. If you look at some of the numbers that have come back from, again, initial studies, they need to be examined more closely. In Los Angeles, Santa Clara County, they have basically indicated that perhaps we've had about maybe 3 to 4% of people in California actually perhaps have gotten exposed to the disease based on antibody studies. Now, I should point out the antibody studies does not necessarily mean that they're actually immune. We do not know that yet. All we know is that they have antibodies to this. So we do not know if all 3 to 4% actually are immune. So, but I would point out that even at 3 to 4%, which would be, perhaps a 50-fold increase from the number of people who actually tested positive for COVID, that still is way below the community immunity or herd immunity level we would need of approximately 70 to 80% of the population. So if you think about the number of deaths we have now, multiply that out, we would have many more deaths if we simply lifted the limits. Now, if you want to talk about New York, again, another contrast, as I mentioned, over 11,000 deaths in New York City alone, not New York State, New York City alone. And they just came out with some numbers indicating that perhaps 20% of people living in New York City have antibodies to COVID, and they've already had over 11,000 deaths. So if you have to get to community immunity or herd immunity at 70 to 80%, imagine taking that number and multiplying that 4-fold in order to get to that point, the number of deaths. So I think we need to definitely take this seriously. And the reason I'm emphasizing this so much, because unfortunately in the political dialogue, there is a small number of very vocal people, but unfortunately they seem to have gotten the ear of certain political leaders that we should just go ahead and lift the stay-at-home orders. So the consequences would be severe. And so if you think about what's happened in New York City, the horrors that happened in New York City with the fact that their funeral homes have been so overrun that they don't have places to put all the bodies, that the healthcare workers have been overwhelmed. And that with what has happened, that they have run out, they basically having challenges with the number of ventilators and hospital beds. And yet, despite all of that, they are only at 20%. And that we need closer examination of those numbers, 20% of people potentially having been exposed. And so there's many, many more people yet to be exposed. So getting to the question about when do we lift it for schools? Well, I think that what we have to do, and Governor Newsom's laid out a plan for how we are going to eventually lift. What we have to do is we have to be able to first of all, wait until we have a downward curve in the number of cases. All right, so we have to continue our stay-at-home orders, keep that physical distancing from each other until we have a downward curve, so that we have 14 days of at least declining numbers of cases. Then what that means is that we are getting a manageable number of cases. Then what we have to do is that we have to be able to test everyone who has symptoms. And then what I have to do is then we have to test, and then we call it trace. So we have to contact trace all their contacts, okay? And then test them. And then we have to isolate everyone who's positive. All right, so that's why we're working very hard to expand our testing capacity here in the state of California. We can already run over 10,000 tests a day. Our goal is to get 25,000 tests per day by the end of the month, but we probably need to get somewhere around 80,000 tests a day in order to successfully do that. Then we also have to trace, which means we need to be able to track all the contacts. That's going to require additional staff at our public health departments. That also means that we have to have a conversation about the use of technology. So we talked about Taiwan earlier and certain other Asian countries. To what degree are we willing to allow our electronic devices to be used as a way to trace where we've been and who we've been in contact with, as a way to, again, be able to do the contact tracing? We can do it manually too with people. We'll just have to hire a lot more people then in that case. All right. And then finally, isolate. We have to isolate everyone who's positive or who has been contact with the positive person needs to be isolated. They need to stay home for 14 days, right? If they test negative, then perhaps we can let them go a little earlier. So those are essential steps we have to take before we can lift the stay-at-home orders, before we can allow our kids to be able to go back to school. Now, the other thing, as the governor also noted, is that we have to monitor the overall number of cases. And if it looks like it's starting to rise again, we may have to basically shut things back down again. So he talks about this is not an on and off switch. This is like a dimmer switch, right? So what happens is we slowly, looks like we're heading the right direction. We're able to identify all the people who are positive and their contacts. And then what happens is we can then slowly loosen up the restrictions. But it looks like the number of cases is starting to rise, the hospitalizations are rising, the deaths are rising, then we may have to increase restrictions. In fact, we've seen this in other countries. Singapore right now, which started off being able to manage their COVID-19, is now having to go through, they're implementing widespread shutdowns because they unfortunately have not been able to keep it under control. So these are the types of things that we are going to have to do. But I think we have to also remember that a vast majority, even in places like New York, where they had a tremendous number of cases, we still have many more people who have not been exposed to this virus. We are nowhere near the point where there's enough people who are immune to this virus that we can just go ahead and release without causing a very large number of deaths. And so even if we talk about what we have here in California, we already have, again, 1,354 fatalities. Those are people who have loved ones who are lost to us. That's with our physical distancing. That's a success. But yet we still have such a level of loss. If we don't do it, it will be magnified multiple times of that. many fold. And even if you look at New York City at 11,000, that's only a fraction of what could be. So we need to work hard to expand our testing, expand contact tracing, do isolation. We need to carefully monitor this. We need people to work together. The other problem I should also mention is that so some of the other countries, what they've done is they limited entry into their country. Now, our challenge here in the United States is that we have different states pursuing different policies. And so the problem is that those people in states where they are not implementing stay-at-home orders, where they're not trying to limit the spread, those people can travel to California and other states, and we cannot force them to be tested at the border. We cannot force them to be quarantined at the border of our state. So we are only as strong as our weakest link, and that's why we need federal leadership in this issue, because we are one country. And so in terms of policies, we need to be sure we have a consistent implementation across the country to be sure we don't have this disease continuing to spread. Certainly it will be worse in those states where they have prematurely lifted, but those people can continue to travel to other states, and we are not able to stop that. So again, here in California, thank you. You've done a good job. We're all hanging in there. I know it's tough. It's difficult. Believe me, I look at our unemployment numbers and how they're spiking up. I get it. I see people suffering. It's hard, but the alternative is even worse. And we need to keep that in mind. We're going to try to do what we can at the state to help people. We need greater leadership by the president in this. I appreciate the work that Congress has done as well to try to help support our small businesses and people who are unemployed and others. But this is something where we're all in it together. We need to work together. We need to be straightforward with people, be honest with people about what the alternatives are. Thank you.
Thank you, Senator. Stay around. We have more questions for you. Lots of interesting questions coming. We are going to be sharing these questions through the chat, questions that come from the chat and the pre-submitted question. But now it's time to talk about the remdesivir and the other medications. People are anxious about that. Many questions about this. And our next speaker is Dr. Stuart Cohen. He's Chief of the Division of Infectious Disease and Director of Hospital Epidemiology and Infection Control here at UC Davis Medical School, and he's the man in charge of the trials with this medicine. So he has clinical trials to treat COVID-19, serological testing to evaluate utility and epidemiology, hospital infection control related to SARS-CoV-2 infection. So I want to clarify, because there are some questions over the chat, because the terms COVID-19 and the SARS-CoV-2 are being used. The disease is officially COVID-19. The virus that caused the disease is officially named SARS-CoV-2. That's the confusion that I get some question here from the chat. So now I turn to Dr. Stuart Cohen for his presentation. Do you want me to present from here, or you're going to display the slides there?
I sent them to you, so you
can
put them on.
I'll be glad to do that.
It'll be easier.
You may start.
Okay. As soon as I see it pop up.
Aren't they there yet? Okay, so
Yeah.
Get back here. All right, so sharing and
okay. Whoop.
What about now?
Okay, good. Okay, that is so I was asked to discuss a bunch of different things. So thanks, Dr. Leal, for inviting me again. The last time I think we met was to talk about Zika. So we seem to meet with every epidemic or pandemic. And so I will move to the next slide. And I was gonna, which are the clinical manifestations, which I was also asked to discuss, and treatment. And I was on another Zoom call, so I missed the first hour and a half. So if some of this is review, I will move through it quickly. Next slide. So I have 3 primary objectives. One is to describe some of the epidemiology of COVID-19, to define the clinical manifestations and recognize potential antiviral treatment for patients with COVID-19. So the next slide is a little bit about epidemiology. So first, in echoing what Dr. Liel just brought up, it's caused by SARS-CoV-2. So for those not familiar, SARS-CoV-1 caused SARS. When these were sequenced, they were very close together. And so this is where the name came from. The transmission is by droplet and contact. There's been a lot of debate about whether aerosols are an effective way of transmitting. I think aerosols are effective in transmitting in healthcare settings where people are actually doing stuff to generate the aerosols. But if airborne was a primary route of spread, I don't think sitting 6 feet apart or wearing a little paper mask is going to make any difference. And so it does suggest that the majority of transmission is by droplet contact, even though you can aerosolize viruses. And I point out all the time that you can aerosolize influenza too, but no one even thinks of flu. Even when they're doing procedures in the hospital, they're not thinking that it's really airborne. It also is shed in the stool, but there's no evidence of fecal oral transmission either. Incubation period is typically up to 14 days. The mean is about 6 days after infection for onset of symptoms. People are infectious for about 48 hours before they start having symptoms. And then within the first day, I think some of the studies say 0.7 days ahead of onset of symptoms is the highest risk for transmission. And then viral shedding goes on for a really long period of time. We had a patient here in March who's still shedding now, beginning of March, I think 1st or 2nd of March, and a couple days ago was still positive. So 2 months of shedding. I don't know whether people are infectious still, even though we can detect RNA. Next. So as I mentioned, incubation period, 14 days, mean is about 6, but most happen within 4 to 5 days. And 97.5% of cases in the Chinese experience occurred within 11 and a half. The spectrum of illness was mild disease, 81%, severe disease, 14%, critical disease, meaning respiratory failure, about 5%, and the case fatality rate was 2.3%, and they didn't look at asymptomatics. And one thing I think most of you are aware of, but I'll just point out for people who are not, you know, when a new disease pops up, we come up with a case definition. The case definition, for the most part, typically identifies the most extreme aspects of the disease. So back in 1981, when AIDS was first identified, we didn't know how many people were HIV infected. It took 2 years to even figure out that it was caused by HIV. But then we got a spectrum of disease once we had testing available for us. I think right now that's the way that this looks too, is that the initial patients were the 19% with either severe or critical disease. And then we start moving the bell curve back, including potentially asymptomatics. The next slide addresses some of the asymptomatic issues. Oh, no, it doesn't. It looks at risk factors. The one after that will be asymptomatics. So this is the information that we have. So there was, you remember that famous Japanese cruise ship that floated around in the water for a long time. 18% of the people on that cruise ship that were positive never had symptoms. In addition, at the nursing home in Washington State, which had initially the biggest outbreak in the United States, about a quarter of the patients at that skilled nursing facility never became symptomatic. So a lot of times you'll identify people, but they'll be pre-symptomatic. They will be, ultimately they will have symptoms. They just don't have them at the time that you're testing them. And then I put this picture up from a New England Journal of Medicine article from pregnant women in New York City who were being tested upon arrival to deliver their babies. Only 2% of them were symptomatic. Of the others, 13.5% were asymptomatic and were SARS-CoV-2 positive. So the issue with that is basically that the prevalence in New York is much higher. So I don't suspect that we would see that here. In fact, we're testing pre-op patients, we're testing pregnant women coming in for delivery, we're testing other people in specific groups. We've had 0 positives in our asymptomatic screening to date, and it's been multiple hundreds. Next slide. Okay, so this is just the clinical features. I took this from a critical care textbook. I'm not a critical care guy, but I guess I wanted to point out just a couple of things based on this. First, you can sort of see that severity of illness on the y-axis, and you can also see time course on the x-axis without actual days on it. But what most of us have seen is that there is this period of time, typically as far out as a week, where people are mildly symptomatic and then they seem to fall off a cliff. And they go into that stage 2, that pulmonary phase, where they start having more of a host inflammatory response and they end up getting sicker. Not everyone does this. Mild disease stays mild in most people, but a lot of times, even though patients come in acutely ill, if you talk to them, they've been sick for about a week before they really decompensate and show up. And that's when they have shortness of breath and hypoxia, which is low oxygen in their blood. And then ultimately the hyperinflammation stage, they end up potentially in shock and on a ventilator and maybe have heart failure. And what they put at the bottom in tan are the potential drugs and when they may be potentially useful. Particularly these host inflammatory response drugs, which we'll talk about briefly, seem to be potentially better off at the later part of the illness. Next slide. And this I just put in to point out that so many organs get involved. It's not just lungs. This is taken from a science paper, and it's not a PDF. You have to go online, but you can click on each one of those organs and it'll show a picture of the, right, it'll highlight the different organ and what the symptoms are as you walk through it if you're interested. Next slide. This is from the Chinese data, and this just shows you a lot of the symptoms. I think that you can see that there are a bunch of different things. In the people who end up in the ICU, the biggest problem is shortness of breath compared to those that are not in the ICU. And also sore throat, which is pharyngealgia, and to a much lesser degree abdominal pain and dizziness. But I think you can see that 10% of patients have diarrhea, even though you can't differentiate the severe from non-severe patients. And there are a variety of other symptoms that go along. And you can see hospital admission ends up about after a week. And the ARDS happens about 8 days after the onset of symptoms. Next. So, and this is just what a CT scan looks like. So the only normal lung is right up at your top left, the white or the black part. Everything else is abnormal. And so it can be quite severe, involving the large majority of the lung. Next slide. There are a couple of other unusual symptoms that have popped up as part of this complex. One is that people can't smell. That's anosmia, and they get bad taste. That's often mild outpatient disease, but not uncommon. If somebody says all of a sudden they lose their taste of smell or taste or sense of smell, they need to be tested. I already mentioned headache, sore throat, and rhinorrhea, runny noses, neurologic disease, there's an increased risk of stroke, cardiac disease, there's an increased risk of heart failure, diarrhea I mentioned, and then I put this picture up that I received from a WebEx from CDC of what's called COVID toes. So the red ends of the toes are typical. They tend to be younger patients that are not very sick, and but they hurt. It's not just that they're red, they actually hurt. Next. This you don't have to worry about the picture. I listed the drugs because this is the treatment part. So remdesivir is an adenosine analog, so it blocks RNA synthesis. Hydroxychloroquine inhibits fusion by decreasing the pH in the lysosomes when the virus gets into the cell. Baricitinib, which is going to be included now in the NIH trial, and I forgot to turn this black endocytosis into white, but it also blocks some of the virus getting into the cells. And then lopinavir ritonavir, which is an antiretroviral drug, is a protease inhibitor that didn't appear to work very well. Next slide. So this is taken from the New England Journal paper, and I'm not going to go into any detail on this because people have probably already seen it. But just in case you haven't, you'll be able to have access to it. This is a non-randomized study of 53 patients who got compassionate plea remdesivir. And so, and you can sort of see the demographics of the patients. It was generally a sick patient population. 34 out of the 53 were on ventilators. Next slide. And they used this system to define whether patients got better or not based on this 6-point system, which includes being discharged as one and death being the other end of the scale. And then based on where they were at the end of treatment, they decided whether they had improved or didn't improve. And so the stuff in light blue is improvement. The stuff in lightish gray are no difference. And then the dark gray, they actually were worse. And so this is where that 56% improvement comes from. So you can sort of see that there was something today that I saw about this Chinese study that was leaked that suggested that remdesivir didn't work. And it looked like their endpoints were death, but that thing leaked, it was reported on, and then it disappeared. I can't find it anymore. And so I have not been able to really look at the paper, but there is some question based on that, whether they were better or not. But if you're just looking at mortality, that may not be the optimal endpoint to be looking at. Next slide. And so this is the Kaplan-Meier curve on the left of how long it took for people to get better. So they were followed out to 30 days. And so that's what you're seeing there. So it was slow improvement. And you can also see that people over age 70 generally did worse than people under age 70. And I've said this before, happily, I am 67, so I am not quite in the totally not so good group. Next. The NIH ran what's called the Act 1, which stands for Adaptive Clinical Treatment Trial for COVID, and it is closed. They've enrolled well over 900 patients. It's a placebo-controlled randomized trial, which is the way that it needs to be done in order to determine whether this drug is working or not. I expect that we will probably have some data in about a month, and we will see whether it makes sense or not. That trial is now being rolled over to Act 2, which will now use baricitinib, which is an anti-immunologic drug as well as an antiviral, and it'll be remdesivir, placebo, baricitinib, or combination of the two. And so that's going to be the next iteration of this adaptive trial. That would obviously change based on what the results are with remdesivir. Next slide. The other choices are more immunologic. So convalescent plasma, which is now being given, is available via the Red Cross. There are a bunch of different protocols, one with really sick people, one with less sick people, and then one for post-exposure prophylaxis. So if somebody actually ran into somebody with COVID, they could be potentially treated. There are a bunch of interleukin-6, so that cytokine storm target. One is called serilimab, which is being done at Davis as also a placebo-controlled trial. Tocilizumab and siltuximab are available, and people can use them off-label, but I think that it's a little bit dicey with those because they are immunosuppressive. That's what they're used for now, right? They're used for rheumatoid arthritis, or they're used for these bone marrow transplant patients that get a sterile cytokine release syndrome. So they're very different. And so it's a little bit dicey, but when backs are up against the wall, people do different things. And baricitinib works as a JAK1, JAK2 antagonist, so it blocks some of the cytokine signaling more globally. And then beta interferon also appears to be potentially active. Next slide. Thank you. Questions. So I went a couple minutes over, but not too much.
That's perfectly fine. We have questions that have been pre-submitted, questions that come out now through the chat. And this is one question that came, was pre-submitted question. Would you be able to comment on the recent rumor that COVID-19 tends to cause blood clotting and that blood thinners may be a helpful treatment, maybe more helpful than ventilators? It would be wonderful if remdesivir coupled with blood thinners could reduce the death rate. Can you answer that question?
Yeah. So yeah, I think it's more than rumor. Patients with COVID are what we call hypercoagulable. They have a much higher risk of clotting. The part of it is all the immune activation will trigger the endothelial cells, the linings of the blood vessels, to trigger some of the clotting. And then the whole so-called sepsis cascade also is procoagulant. And so there are a bunch of reasons why people have high risk of clotting. And I think in most ICUs, patients already get a couple of medications to try to prevent clotting. Some of the questions are whether the doses need to be higher because there are people who are still clotting. So some of this needs to be clarified. I don't think that it's necessarily more helpful than ventilators. I think it would be adjunctive, right? So you want something to stop the virus from multiplying. You need something to allow the lungs to heal, to get over it, which is where ventilatory support helps. And then you need to either prevent or treat the complications, of which blood clotting is one.
All right, so thank you very much. There is a question here for Dr. Cooperman, and I'm going to ask him to answer that question while I prepare for the next one. It's a question from previously submitted question from Susan Shorey. When a loved one is in isolation at the hospital ICU, is HIPAA regulation loosened so that patient information can be shared over the phone to family? Dr. Cooperman.
Yeah, so that's a really important question. And the answer is yes, is that HIPAA regulations have been loosened in this really chaotic pandemic so that we are allowed to do communications in a way that we were not allowed to previously. So as long as somebody identifies themselves conclusively as a family member, we do share information by telephone, by iPad and Skype and other sort of online vehicles, because we have a strict visitor limitation policy. And one of the horrific aspects of this crisis is people being critically ill and even dying alone without their family members. So yes, we are able, based on changes in HIPAA for this crisis, to communicate in a way that we haven't before.
All right, so here's another question that comes from previously submitted question. I am home with an untested case of C19. Is it loud experience and different from any flu that I have before? My UC Davis primary care doctor agrees that I have it, but they did not want me more at risk by leaving home for testing. I agree. So we talked to the patient number 1 in Yolo County, and she didn't have it, the standard symptoms that we were people talking about. So let's hear her story first.
Yeah, my name's Marilyn Stebbins, and I tested positive for the coronavirus in early March. And I was the first case in Yolo County. And interestingly, 50-some days later, I continued to test positive for the coronavirus, but I also was able to go out for a run and do my Pilates class. So I don't think I'm really the classic case for one, who I thought the coronavirus attacked, and 2, my recovery.
On March 4th, you test positive for coronavirus. On March 13, you test positive to coronavirus. On April 2nd, you test positive to coronavirus. April 17, you test negative. And you need 2 negatives to be considered free of coronavirus. And we get another positive. And you tell me that you run and you did exercise, you have no symptoms of a COVID-19 patient. So what do you think is going on here?
You know, it's really difficult to tell. I think that's the nature of this virus, is we know so little about this virus. We just have, you know, the experience and some of the early research out of China on this virus. And as we start looking at our own cases, I think we're going to see that there may be more people like me. I'm an early case, and we, as I said, don't have experience with this virus. So we don't even know what normal is. I think it is fascinating that obviously from a population level, I appear to be an outlier because our CDC guidelines really look at recovery as either 14 days from original symptoms or 72 hours after last symptoms. And none of those seem to work for me. So it is fascinating. I have to say, the recovery initially was a bit tough when I came home from the hospital, but literally like a light switch, overnight, I improved.
You mentioned that your symptoms were cough, nausea, headache, and GI problems, and you have also a respiratory problem, but it was not the main problem that you have. Your symptoms is quite different from other people that are COVID-19 patients.
Yeah, initially, and not just initially, but throughout the entire process, I never had a fever. Interestingly, I had chills. And I would take my temperature and it would be 95. It wouldn't even be 96.8, it would be 95. So for some reason, I just didn't mount a fever. What I called sort of my first real symptoms that bothered me were GI symptoms of nausea and vomiting, which I thought were food poisoning. I did have a sense that I had some burning in my lungs, but I was skiing and felt that it was because of my activity level and being at altitude and cold weather that I was having that problem. And I think what actually took me to UC Davis and actually my initial encounter to the ER were my pulmonary symptoms, my respiratory symptoms. I was short of breath. I felt so viral. I really felt like I had the flu. I had no thought of it being COVID. It was that early. I just felt like I had the flu, and I was like, you've got to test me for the flu. And when I told them that my lungs were burning and they did a chest x-ray, that's when they said, oh, you've got community acquired pneumonia, take some antibiotics and wear a mask and see your doctor in a week because your x-ray looks far worse than you do. And so it was a strange sort of experience, but I expected, I'm a pharmacist, I know how antibiotics work. I expected to get better, even within 24 hours, and I didn't. I got worse over the weekend. And it was that following Monday that I just said, I can't be at home anymore. I'm not safe at home. And went to the emergency room at UC Davis.
Can Dr. Cooperman or Dr. Cohen comment on this kind of anomaly?
Yeah, so she was cared for by a number of my colleagues, and timing was such, I don't think if she had showed up 2 weeks earlier, she would have been allowed to be tested, right? And the timing was such that we had just identified the first case of community transmission in the United States, and that allowed us to do a little bit more testing, and that's part of how she was picked up. And if I remember correctly, she had gone skiing in Idaho and made a plane change in Seattle, which was potentially the place where this was picked up. But we really don't know, right? I mean, we have this information now from Santa Clara that there were cases in California before it was even identified as a disease. And so I think that, and I think the prolonged shedding, so that's part of what I was trying to allude to in the presentation, is that we know people shed for a long time. I don't know whether anyone is infectious after a week or after 2 weeks, and CDC gives you 2 paths back to quote unquote being clean. I should have a better term for that, but I don't right now. So one of them is to say, you've had the disease for at least 7 days, but you are now symptom-free for 3, then we would consider it okay. And if it was a healthcare worker, we'd have them come back wearing a mask, which we're all doing anyhow now, and they could work. If you do the testing route, it's 2 negatives separated by at least 24 hours. So as was the case with Dr. Stebbins, the test was negative and then positive again. So she never really reached what we would consider clearance. You would expect that the viral load is down because if you miss, there's probably less virus there. But I don't think that she's been really infectious since she left the hospital, which was a month ago, right?
Right. Yeah, and just to add to that, the comment that you made about Santa Clara, I think they report yesterday there was a death in February 6th that was related to coronavirus, which is a very early date. Dr. Cooperman wants to comment on that, and there's also a couple of questions here that I'll put together so that he can address all of them at once. How many hospital personnel have contacted COVID-19, and how are you doing with ventilators and PPEs, what percent of ICU beds are now occupied with COVID-19 patients? How are you separate COVID-19 patients from other patients? And how are you handle treatments, tests, or visits that fall between emergency and routine? This is a question from Glenn Benson, and I think it's a very loaded question.
So yeah, I can comment. You'll have to remind me of the thing. One thing I'm just going to quickly comment about Professor Stebbins. As I mentioned at the start of my presentation, as this disease has emerged, remember this has just been with us for a couple of months. We've learned a lot of things along the way. So things that we would have done perhaps a month ago, we would do differently now because we're learning lots of things. I also mentioned, and I agree with Senator Pan, we've been blessed by really enlightened state leadership. So because we've bent the curve, we have not outstripped our resources. So let me give you a little bit of the data around that. We have, for example, approximately 140 ventilators immediately available to us here at UC Davis. We're only using 40, so we have 100 free ventilators. We have plenty of personal protective equipment. And one thing you have to understand in this pandemic, of all people infected with the SARS-CoV-2 virus, about 20% are healthcare workers. It depends on the data that you read, 15 to 20%. So it's a very high percentage. Here at UC Davis, in total, we have had around 40 healthcare workers infected. All of them are either recovered or recovering. And in the emergency department, we have had only 4 healthcare workers infected. And I think all of this has to do with, I don't want to pat Dr. Cohen on the back, but he's a good friend. But the reality is that UC Davis has been on the kind of leading edge with regards to safety and protective practices, is why I like to think that we actually have a very relatively low number of infected hospital workers. Walter, what other questions were in there?
There was this question, and how does hospital justify having their employees wear cloth masks, reusing PPEs, or providing instruction to the public for making cloth masks when they are promoting the spread of infectious disease?
Yeah, so let me comment on that. We are not reusing masks. When we take our masks off, we get a new mask. We were, of course, at the start of this pandemic, and there is nationally, to be very frank and honest, there is a national shortage of PPE. Our colleagues in New York are having, at some centers, are having quite a go of it with shortage of PPE. Here in California, here at UC Davis, we have not experienced that. We have plenty of PPE, so we are not reusing masks, and N95s are strictly reserved for operations or what we call aerosolized generating procedures like intubation, which I mentioned, putting a tube down somebody's lungs. So we're not reusing them. And with regard to the type of masks, we only use surgical masks or those N95s. Cloth masks are only meant to be used at home. when you're going out to the grocery store or to the pharmacy for necessary trips from the home. But we are not using those masks in the hospital.
Very
This
good.
is Richard Pan. Let me just add on to some of that, though, from a state perspective. As of April 21st, we've had 3,877 confirmed positive cases in healthcare workers. Now, these are not necessarily all on the job. They could have come from some other exposure. In terms of the PPE, we are working hard to get more PPE. I think by flattening the curve, we have reduced the times in which there's limited PPE, but I do want to recognize that we still need PPE, not only, of course, for our healthcare facilities like hospitals, but also for nursing homes, other types of facilities, and then even for some essential workers as well who may be exposed. So we've worked hard together to try to keep this disease under control. We have been, I think, relatively successful in doing that, but we could easily lose all of that if we prematurely lift our physical distancing, stay-at-home orders. So again, we're working hard to get more PPE, because more PPE not only, of course, is about protecting people against COVID, we also need it for people conducting the tests that we need to scale up, especially the PCR tests, because if you have to get close enough to stick a swab down someone's nose, you could potentially get exposed. So sometimes that can be a limitation on testing when you don't have enough PPE. We've also talked about the fact that despite the fact we have COVID, we also have people who have other healthcare needs, like getting surgeries or cancer treatments and so forth. And some of those types of procedures also require using PPE to protect them against other forms of infection. So we are working hard to try to increase the amount of PPE so we can scale up testing, we can bring back more healthcare that people do need, as well as, of course, take care of all our COVID patients.
Thank you very much, Senator. There is another pre-submitted question. Would you agree that there are likely 3 to 5 times more people in the US with C19 compared to the test data we are reading, since you have so few are actually being tested? Is public health considering moderate cases asymptomatic case? So I went back to the patient number 1 to complete her story.
Yeah, at the time it was really incredibly frustrating. And I think, I'm not a young woman, I get that. But my whole objection with being described the way I was described is that as an early patient, I wanted people to know that fit, relatively, or maybe middle-aged people were getting this and they were ending up in the hospital. So I felt that it was in the public's best interest. Now, I appreciate Yolo County has changed their procedures, and now they list the age of the patient. They don't categorize them as older or elderly. So I think that they made positive changes, and I really appreciate that. I think we have to have a learning health system that is nimble and can change. But I will say that it was really tough to go home. It was tough to go home for the reasons I mentioned previously, that I was presumed positive and we didn't know the status of my husband. You get cared for 24/7 in a hospital, and then you go home and there's nothing. And I was released, they release you and say that you will be followed up by the county public health, and you don't hear from them for several days. And so that's tough. And I really believe that all of us can do better. We can all improve our system. I was the first patient. I completely forgive anyone for any errors or mistakes made, because we all do that in times of, normal times. And this was a time of crisis. So my message was, we need to learn from this. We need to coordinate. Sac County and Yolo County at that point sort of had some different guidance. What they were getting from the CDC, from the Department of Public Health, they were following all their own guidelines, and I can totally appreciate that. But the system it's not a patient-centered system. And patients really are the ones that have this disease, and they're the ones whose families have to deal with it. And I think it's our responsibility as healthcare providers and healthcare systems to take an honest look at how we can improve the system for our patients. And I think that's my message. I wrote my story for that reason. I wrote it because I'm an educator. I wrote it because I believe in quality improvement. This is nothing that I wouldn't do with my students, give them, this case study to dissect and do a root cause analysis and show how we can improve. And I think that was my intent, as well as it was therapeutic for me to actually tell my story, I think.
There is lots of concern about the CDC guidelines and the healthcare outside of the hospital. She tells good stories about the treatment that she received at the hospital, but very much concerned about what the treatment was outside of the hospital. Here's a comment, a public comment that came in the meeting the day before yesterday.
We have many unanswered questions regarding the county's inaccurate reporting of that first Yolo County COVID-19 case. As a matter of public health, we think the public has a right to answers, and we've not yet received them from the Yolo public health officials. We're hoping that the board can help us get those answers. The first question we have is, we'd like to know why the original March 6th press release has been edited, but it makes no reference to a correction or the original misinformation. The second paragraph there was changed from "this individual is an older female with underlying health conditions." It now reads "the individual is female," but it doesn't reference the fact she was actually a healthy athlete with no underlying conditions. And ironically, the next paragraph in the press release references misinformation in our communities, but makes no reference to the misinformation from Yolo County Public Health. So we're hoping that you can help us figure out why that correction has not been made very clear in public. Secondly, if Yolo County knew in early March that it had issued false information, why didn't the county immediately issue a public correction to help clarify the risk for healthy adults? To date, it appears the only public reference to the error was a press release that was issued this weekend, basically reacting to news reports. It's now a month and a half later. Some feel that if the public had known that first case was actually a healthy athlete and not an elderly sick woman, it may have provided crucial information and context and potentially help save lives. And finally, we'd like to know if that nail salon worker that she had contact with has now been contacted and or tested. We understand that it's not necessarily protocol from the California Department of Public Health to contact store employees like manicurists, but we're wondering if understanding how she might have been impacted, if she ended up getting sick, if that would help provide context on spread, even when someone was wearing a mask, because as we understand it, that manicurist was wearing a mask. Thank you, Board.
I'm wondering if Dr. Maverax would be able to comment on the lack of testing, especially, for example, her husband was not tested, the manicurist was not tested. Do you have any comments, Dr. Maverax?
Specifically on people being tested and not being tested and tracking down people being tested?
Right, in general.
I have lots of problems with the testing. And this is because there are no, and so I'm sorry that this isn't going to answer the question perfectly, mainly because I didn't put full attention to this question. But what I do want to say is that there are tons of problems with testing and follow-up on tests right now. One of the main problems with testing is that there are no national reporting guidelines for COVID-19. So, which is a huge problem. We want to be able to crunch the data and get as accurate information as we can to the public, but there's nothing that has been, established by groups of information scientists, physicians, and experts in the field that have said these are the points that should be transmitted to the CDC or to the state. And what gets transmitted, if I remember correctly, is just like patient's name, living condition and contacts, sex and age or something like that. Very simple information gets transmitted. And then yes, they do contact tracing and stuff, but you could imagine that if we standardize what was transmitted and we transmitted some more useful information, then we could start building models and also we could transmit stuff that would help a little bit with the contact tracing. But the CDC is probably way overwhelmed now to do extensive contact tracing on people. So I think a lot of this is going to have to come in from the states, and the state of California could do a lot in establishing their own reporting guidelines for the tests. As an example, let me just give you an example. So if we're reporting just a positive test, and we're not reporting the denominator, then we don't know if this spike is because 10,000 people decided to get tested that weekend, because we could actually test like 1,000 a day or something now. So like if 10,000 people this week decided to be tested in this one area, and that's why it's spiking. We don't know anything about these people when they come in to be tested, when it's transmitted. For example, we don't know how many of them had fevers. We don't know how many of them had low O2 sats. We don't know how many of them had underlying conditions or these types of things. So there are certain data points that would be very interesting to transmit, not only on the positive test takers, but also on the negative test takers. So if you knew information about all the people, then you could, like, for example, Nate, Dr. Cooperman, was saying that now, if you're coming in, the flu is gone, so your symptoms have a higher chance of being from COVID. Well, we would know that if we were monitoring a few things. Like, it has to be feasible, but when the person comes in to get their test taken, you could quickly snap a temperature. You could quickly give them like a five questions that we feel are most important for data collection. Like, what symptoms do they have? Like, how many people, like our patient number 1 said she mainly presented when she had diarrhea and vomiting or something like that. So how many, what exact is that percentage? Like, how many people are coming in with diarrhea and vomiting that are getting tested that aren't positive? How many that are coming in that are getting tested that are positive? So we really need some, at least California guidelines on reporting guidelines. And these could be easily established in a day or two. You just, there's an exercise called a Delphi exercise, where my group is expert at conducting these types of exercises. But those types of guidelines could be done in a day. That would be incredibly helpful. In terms of this one, I'm sorry, I don't know any details about this case and why the nail salon wasn't contacted or things like that. But a lot of it is from, like, the CDC is or they weren't overwhelmed then, but they're overwhelmed now. So I don't think that they're doing good contact tracing at this time because there's just way too many cases. But the state of California could do that. I don't know anything about what the state is doing in terms of contact.
So can I make a couple quick comments?
Before we go on, can you hold, please? Dr. Cohen?
Yeah, I just wanted to make a couple quick comments.
Yes, please.
So first, I think part of the reason that her husband didn't get tested is because there weren't enough tests. So the initial testing problem that everyone is well aware of is that there weren't enough tests, and no one would allow anybody to test an asymptomatic person. As I say, when we saw her and we decided that we wanted to test her, 2 weeks earlier, she wouldn't have met criteria to get tested. We had credibility because we had pushed one through already. And so people had listened. We also know that, at least within our facility, that approximately 5% of the tests that we do are positive. So we do have denominators within the health system. I think that California early on made a decision that they were going to approach COVID by a mitigation strategy, not necessarily by a contact trace based strategy, which may or may not have been the right decision, but that was the decision that was made. And so that's part of the reason that people were not actively tracing people, because we didn't have the capacity to test them. Right, if we brought in 20 people to test at the time that Dr. Stebbins was identified, we would never have had enough tests to even test them. And so there were a lot of mitigating factors. we were not prepared as a country to get our acts together. And as good as California's been, we all were put behind the 8 ball with testing because we didn't have enough tests. And people had to jump through hoops to get tests approved.
So Dr. Cohen, I think that's incredible that we know that 5% of the tests are positive, but what about like what those, what percent of the patients that had fever tested positive, or what percent of the patients that had abdominal symptoms tested positive?
I can't tell you that because I don't have enough personnel to go through all that either.
Exactly.
I will, right? We're trying to keep our heads above water.
Absolutely.
I think that we would love to be able to do that. I agree with you. What I did mention, though, is that we are doing screening of asymptomatics that are undergoing high-risk procedures. And we know that to date, 0 have been positive.
That's great.
So we know that community spread is modest, but clearly there is community spread. And we don't really have a good handle on the epidemiology. You're totally right. It's hard to figure out where we're going when we don't know where we've been. But we have to move forward. And now, at least at Davis, we have the testing capacity, as you say, to do 1,000 tests a day. We're also going to roll out serologies, which have intrinsic problems associated with them as well, which includes that if you don't know what the prevalence is in the community, it's hard to interpret a serology because sensitivity is one thing, but positive predictive value, knowing whether a test is a real positive, requires a denominator.
Yeah.
And if we don't have a denominator, we can't really do that yet.
Yeah.
Can we go back to that in a minute, because we are run out of time.
Okay.
We're going to extend the meeting so that we can answer most of the questions.
So
We have
actually, I think since the state of California was referenced, I believe I should be able to respond to some of that.
Senator, can you hold for a second? We are going to go back to that issue, but we have to run here because we have too many questions to take care of. So
Okay,
one of the
but
questions—
the state of California was referred to, so I feel like it needs to be addressed.
Yeah, we'll go back to that. No, not a
Because
problem.
I prefer
But-
people
but
don't make
hold
references to the
that-
state of
hold that for
California
the
without having the information they need to know.
Yeah, so hold that. We are going to go back to that, but we have lots of material to cover here. One of the questions is that how does SARS-CoV-2 compares to other coronavirus? This was pre-submitted question. I think Nicole already addressed some of this question. Please explain what SARS and MERS are, and are cats coronavirus similar to COVID-19, which actually the disease, not the virus. But in any case, yesterday there was news from CDC that cats also are getting the beta coronavirus that are in humans. And we talked to a specialist in cat coronavirus who is here from UC Davis.
Well, the COVID virus, the SARS-2 virus, is a beta coronavirus. The cat virus is an alpha coronavirus. So they're in 2 different, what we call types or groups. The SARS-2 virus is a respiratory pathogen. It homes in on the mucosa of the respiratory tract. The feline coronaviruses are intestinal coronaviruses. They also infect the epithelium, but they infect the epithelial cells in the lower intestine, and they're not respiratory pathogens. But this pattern of whether a coronavirus is respiratory enteric is kind of common with all of the various species. They're usually one or the other, and sometimes both. As some of the reports are coming out, you see that some of the patients that are infected with the COVID-19 virus also have GI signs, also have neurologic signs, which we see with other coronavirus species. You know, the cat feline infectious peritonitis virus will get into the brain. And of course, mouse hepatitis virus, which is a coronavirus in mice, also has a propensity for getting into the nervous system.
So when we compare these, the 3 types of coronavirus in humans, like the SARS, the MERS, and now the SARS coronavirus 2. Looks like this one is the mortality is the lowest in this one, but the transmission from human to human is the most effective of the three. Is that correct?
That's correct. SARS coronavirus was the first one, and it was the most that had the highest mortality and the severest disease. Then came MERS, the Middle Eastern Respiratory Syndrome virus. That is also causes very severe disease of the respiratory tract, pneumonia. Both the MERS and the SARS coronaviruses basically failed to adapt themselves fully to humans, and with some minimal control or quarantine, they eventually just died out and disappeared as natural infections. So they never were what we call humanized to the point where they actually established themselves as a pathogen of humans and were easily transmissible between humans. Now, COVID-19 virus, or the SARS-2 coronavirus, is the least pathogenic. The mortalities they're describing now overall are probably less than 0.5%, which is only a fraction of the mortality that we saw with SARS and MERS, which were from 15 to 40% fatal. And there is a relationship, I believe, between their ability to humanize or to transmit or to humanize and be adapted to humans and to be highly transmissible. And it's only the viruses that fully adapt and humanize that do readily transmit. And there is a kind of an old saying that viruses do not like to kill their host. They like to live with their host. So they much prefer a kind of an easy relationship. And that's why so many of our viruses can exist in healthy people without causing symptoms. And coronaviruses are notorious for that. You know, many cats shed coronavirus in their stools without any disease problems. The many dogs shed coronaviruses. Many pigs, many bats, many other species shed coronaviruses all the time in a relatively healthy state. And so I think the fact that the COVID-19 virus has humanized has actually led to it being less pathogenic or less able to cause severe disease. However, it does still cause much more severe disease than the known coronaviruses that cause colds during the wintertime in people. There are 4 species of coronaviruses already existing in humans that cause colds that are carried by many healthy people, especially children, and are of little clinical significance other than causing colds. In fact, they're of so little significance that not a lot of efforts have been made to develop vaccines for them. The only time that we've really talked about developing a vaccine for a coronavirus infection in humans is now with the COVID-19 and the SARS coronavirus 2. It's the first time that we've actually felt compelled to try to develop a vaccine.
Dr. Cohen, that's a question for you. Is it possible for the COVID-19 virus to be a little different or more or less dangerous from one area to another? Could the virus be more infectious or more dangerous in New York than in San Jose, California?
Yeah, I think that it's surely possible. That might be a better question for Nicole or for Niels, but I think that we already have seen that the virus mutates. Based on some sequence data, we've been able to identify clusters of disease, so it mutates some. I don't know whether it adds or decreases virulence. That requires more studies.
All right, so look, I had a floor for the Senator. Nicole, do you want to follow up on that question?
Yes, I was also raised a couple of times. So they are mutations, but so far, actually for an RNA virus, as coronavirus is actually much, much less than, for example, one would see in influenza. So currently, it looks as if the vaccines that are being generated, that the virus doesn't mutate so fast that by the time we may have a virus, that vaccine would no longer be helpful. So I'm quite hopeful that that means that will stay that way. Of course, that will depend.
Senator, do you like to go back to that issue that you had before?
Yes, and I think it would have been better to have addressed it right after he made those remarks so people can connect the two. I think it was very inappropriate for him to simply say that the state can just do this instantaneously, unless he happens to work with the state health department. So I just want to be very clear. I've worked very hard in the state Senate to try to get more resources.
Are we talking
to our
about
Department of
national
Public Health.
reporting guidelines, or
So-
I'm not sure what you're saying instantaneous. Are you talking about?
So when you said that it's just
reporting
simply
guidelines?
easy to collect the data, including clinical data, which doesn't get reported by labs to the state.
It's easy it's very Dr. Pan, it is very easy to establish guidelines. I've established national
actually,
reporting
can
guidelines. So
can I
out of
please
the-
answer
out
the
of
question
two of us, I
first?
think I have experience establishing
okay, well,
national reporting guidelines.
I
You
would
can
just
look
point
me up
out,
in
first of
PubMed in
all,
the Senate for the
okay,
United
well,
States.
if he's
So
gonna
I'm
let me
saying
talk
it
or
from
not, he had a chance to talk
experience. I'm
earlier.
not saying it from out of the blue.
Are you gonna let me be able to say what I need to say first?
Well, what I'm trying to say is that it is easy to establish national reporting guidelines.
Okay, so let the Senator answer the question.
Answer the question then.
Switch on your camera, Dr. Mavericks, please.
Okay, so first of all, I want to point out that the Department of Public Health has received reduced funding from the federal government over time. So we have declines in federal funds to our state and local health departments over time. After the Great Recession, that's part of the reason I've held hearings to talk about how much support we have for our departments of public health in terms of our preparedness. The health departments, as I think Dr. Cohen has mentioned, when the COVID began, basically had challenges in terms of testing. Some of this had to do with the CDC guidelines, but also shortages of supplies, including reagents. So there was certainly a lack of leadership by the federal government when they received information in January and February to respond. They did not respond quickly. And that left, for example, I know that talking to Sacramento County, they had a very small number of tests available. So as much as we would like to have tested more people, we did not have the capacity to do that. The commercial labs did not come on until much later. I would also point out that working with the Department of Public Health in terms of gathering information. So it's great to create guidelines. We can, yeah, sure, the Department of Public Health can post a set of guidelines. The question is, will anything happen after that, right? So to get that information from the variety of different laboratories to the Department of Public Health is not a simple matter. In fact, we've worked very hard to try to actually gather more accurate information. In fact, if you follow the data closely from the Department of Public Health on the amount of lab tests and the results we've gotten, that it took a lot of work. In fact, you probably saw a point where suddenly the number of backup labs suddenly the number of lab results suddenly skyrocketed. That's not because we suddenly did a lot more tests. It's because it took that much time to get that information from the variety of different laboratories. Since we had a shortage, of course, we have to collect data not just from public health laboratories. By the way, I should point out that we have closed 11 public health laboratories since the Great Recession here in the state of California. We have closed that many laboratories here in the state of California. So we have a shortage there. We have, in terms of the amount of staff that we have on place, so we should have been more ready, yes. That would have been great if we had more funding, more leadership at the federal level, where people who would have been directing a response were cut at the federal level. We had decreased funding. I think that, so I'm not saying that everyone did everything perfectly over at the Department of Public Health, but certainly I know that there were many challenges in trying to get test results And also, it's not so simple simply to tell people, you know, we have laboratories, if they have not gotten the clinical data, they can't forward the clinical data to the Department of Public Health, right? They're not on the front lines collecting necessary clinical data, right? They have a lab sample that got sent to them, and whatever information went with that lab sample, and then they run it for a result. So there is a chain of events that have to happen in order for that information to show up. And then you'd have to have the staff at the department to be able to actually collate and organize information. So while I don't disagree, that would be great to have that information. I don't think it's so straightforward to simply say,
Dr.
we need to
Pam,
stick to guidelines and we can get all that information
April
instantaneously.
23rd, and we don't have any guidelines for reporting. It's April 23rd. So one problem is guidelines. Second problem is developing the technology to transmit the guidelines. But you would start with guidelines, and then you would think about the feasibility. Like, you can't just transmit everything because it's not feasible to transmit everything. But guidelines could be established very easily. My group has established NIH reporting guidelines. We have experience doing this stuff. It's not about funding. We're happy to do it for you for free. So it's not about funding. We could do it.
The senator mentioned early on that the process is very invasive. And there is also this question here, is there a less invasive method to collect the samples? The virus is said to get stick to plastic in the other place. How does it need to be collected so deep into the nose? And the good news is that there is a hope in the air coming in this paper that appeared just yesterday in the Med archives. It's a preprint, and that paper reported that saliva is a better source to collect the material. And I talked to the first author of this paper.
So we had the COVID-19 inpatients, and we were enrolling them into a research arm of the study to be able to sort of follow what would happen over the course of their infection. And so for that reason, we were collecting various sample types from them. And we included saliva from the start because the fact that it is a much easier, is a very accessible sample type to take. You know, it's so easy to ask someone just to spit into a cup and to be able to take that. So, you know, saliva potentially has a lot of other applications as well, for such as like antibody testing. And we just thought, you know, this is an easy sample type to collect. Let's collect it along with the other samples. Let's study it. Let's see if there's anything in it and if it can just help us. And yeah, it put us in a very fortunate position to be able to compare it directly, especially when we started running out of swabs and PPE. So,
what kind of sample size did you use for this study?
So this study that we're reporting on, currently what we've published is only on about 49 patients. There's 29 with matching samples, which in total we have 34 matched saliva and nasopharyngeal samples. So this is still a small population size at the moment. But this is our data as of sort of late last week. We are continuing with the study, with this enrollment. We have sort of over 100 inpatients enrolled now. We have over 200 asymptomatic healthcare workers also enrolled. So the sample size as published on our preprint on medRxiv is small, but we also wanted to get this information out as soon as possible because we thought it would, you know, it has a possibility of being transformative in the healthcare settings and testing settings. So, you know, we wanted to make what we knew more widely known, and we will continue to update our results as we go through the review process with publishing.
And what's the major highlight of your paper?
Yeah. I think just to highlight in one of those images, it's the one where we show, you know, sort of more the days, the detection following days of onset. And I think just what our findings really highlight is that exactly, like when you look at the detection in saliva from the same individuals, it's a lot more consistent compared to the nasopharyngeal sampling, where you get someone testing positive and then negative and then positive and then negative and then positive again. It's exactly what other studies are seeing, but in saliva, we didn't see that. And I think that's the biggest sort of promise of saliva, just a much more consistent and reliable sample type as compared to the swab.
And thanks for making the time today.
No problem. Thank you for doing this. Thank you for getting, good information out there.
Thank you very much. So there is a question here, and it's a question for maybe Nicole or one of the doctors there can answer this question as well. If you get the virus, can you get it again a second time if you re-expose it?
Yeah,
you kind of talked about this question before, but can you?
Yeah. So this is a really important question, but one we don't really have an answer to yet. And so we have to base it on other infections. So in most cases, if you've had an infection with a virus and you develop natural immunity to the virus, you would be protected for a considerable amount of time. And the problem is, what is considerable amount of time? Is it a year? Is it 10? Is it 50? As it is in some cases, if you've had chickenpox, as you know, as a child, you'll be protected for life, and the same with measles, and we simply don't know the answer to that. There are some reports that patients that have recovered from SARS, the original SARS virus, have lost antibody levels after about 2 years. But those would have also been, in most cases, very seriously ill individuals where maybe the immune system was really compromised at the time of the immune response. So my prediction would be, and that's, don't hold me to it, but my prediction would be that there would be considerable immunity established with an acute virus infection.
Dr. Cohen, do you share the same thoughts, or do you have a different perspective on that one? The second infection.
No, I agree. I think, right, and they're circulating human coronaviruses every year, as you guys have all heard. And it doesn't seem like we even have immunity for more than a year with those. And so it's all going to be dependent on how long antibodies last, and and whether there's a cell-mediated immune response that in part helps, and what the targets are. So totally unclear. I suspect in the immediate time period, it's unlikely to get reinfected, but down the line, I think it's quite likely.
Thank you very much. I asked my colleague and distinguished professor from entomology and also biodemographer, Jim Carey, to have a look at the actuarial perspective on coronavirus. And he has this study that he came with, especially for this presentation today.
COVID-19 is set apart from all other strains of flu for the simple reason that people die from it at higher rates than from other varieties. It follows that understanding the actuarial details and consequences of this virus is central to understanding its potential impact on the U.S. population in particular and on the world population in general. Here I ask 3 questions. The first is related to case fatality rate of COVID-19. The second concerns the age-specific mortality of this virus. And the third to its demographic consequences were no health-related intervention policies implemented or a vaccine available. So the first question is, how does COVID-19 case fatality rate vary across countries? We define case fatality rate as the death rate per infected individual. It's computed as the number of deaths due to disease divided by the number diagnosed with the disease, which is to say the number of cases. We see here COVID-19 deaths relative to the number of cases in 185 countries. I got this data from the Washington Post. They have it listed every day, updated every day by country and number of cases and number of deaths. So you see here on the bottom that the x-axis, you have the number of cases. This is in a log 10 scale, so every tick mark is an order of magnitude change, the same scale for the y-axis for the number of deaths. The first thing that jumps out of this graph is a huge variation within number of cases for the deaths. And so, for example, you see only 10 deaths for cases ranging from 100 cases to 10,000 cases. Another way to look at this would be for 10,000 cases, it ranges from 10 deaths in some countries to just short of 1,000 cases in other countries. And so you have here some of the points. You have US, which is the highest number of cases and deaths, Italy, China right there. You can see these countries here would be Mexico and Singapore. So you see Singapore has 10 deaths for 10,000 cases. Mexico has about 800 deaths for 10,000 cases. Huge variation. Now, if we look at the frequency distribution of these case fatality rates across these countries. So you see at the bottom would be case fatality rate, and the y-axis the number of countries. So for example, we have Germany and Portugal, fairly low case fatality rate of about 3%, US, China, and Austria about 5%, Mexico and Indonesia 8%, Italy, Netherlands, and France 11%, and Belgium and Nicaragua 15%. If we take the mean of all those percentages by country, it's about 3%, whereas if you look at worldwide and you do all the deaths worldwide and all the cases worldwide, the case fatality rate is about 7%. A second question is, how does the level of age-specific mortality change when COVID-19 is incorporated as a competing risk? We first define age-specific mortality as the fraction of individuals alive at age X that die before age X plus 1. Here is an age-specific mortality for U.S. females in 2017. This is, I consider, the baseline. So we have age on the x-axis and mortality in the y-axis. Here we have 1 out of 2,300 20-year-olds die before 21, 1 out of 700 40-year-olds, 1 out of 150 60-year-olds, 1 out of 25 80-year-olds, and 1 out of 2 are a flip of the coin for 100-year-olds. I used Imperial College Response Team report with data on the case fatality rate. You have age group here on the left column and the case fatality rate on the on the right column. And here would be this baseline mortality as we saw before. And I created an exponential mortality curve that includes every age from 0 to 100, informed by the data from the Imperial College group. So there you have in red this COVID-19, and then if you combine them, you have a baseline plus the COVID-19 mortality curve. And so you can see here that the 65-year-old now has a mortality risk of an 80-year-old. You can say more generally that with no COVID-19 intervention policies or vaccine, the entire population at all ages is subject to mortality risks equivalent to persons 15 years older. So in other words, 80 is the new 65. A third question is, what would be the demographic consequences of 100% of the U.S. population becoming infected with COVID-19 and thus subject to the new mortality schedule? We have here the 2020 U.S. age pyramid, where you have number on the x-axis for males and females respectively, and age class on the y-axis. So that with the U.S. pyramid with the entire population subject to unmitigated COVID-19, you see the band here, this is excess COVID-19 mortality. It totals 5.7 million deaths. We have here estimated age-sex distribution of COVID-19 deaths in the U.S. with non-intervention. So the band you saw on the last age pyramid is now replotted, and so this is the distribution of deaths. You see here again, it's a number in thousands. It's a different scale in age class on the y-axis. There's a total of 5.7 million deaths, as we noted earlier. There's 74 years was the mean age of death for males and females. They differ slightly, but it's fairly close. And there's 70 million person years lost because each of those individuals who died had a remaining life expectancy of about 12 years, as it turns out. The transient demographic consequences of COVID-19 non-intervention are the following. Period male life expectancy, this is cross-sectional life expectancy, and so it's transient. It's currently 76.2 years. It would be reduced to 66.1. Female life expectancy is currently 81.4. It would be reduced to 68.5. Average age in the U.S. is currently 39.3. It would lose a half a year to to 38.7, and the percent of the U.S. population over 65 would be 17.1%. Currently, it would be reduced by over 1% to 16%. The last question is, what will age-specific mortality look like in the post-pandemic world? This is in the category of disaster demography, where you'd have either or both demographic selection and or scarring. And so again, here's our baseline age-specific mortality along with the disaster. The question is, would that red curve return to the baseline? There's a couple, these two different possibilities are that you could have scarring. So for example, you'd have increased mortality due to sustained organ damage, which is one of the long-term consequences of COVID-19 survivors. The other possibility is that where you have selection, and that is reduced mortality due to the removal of the frail, so that those that survived COVID-19 are the more robust, and the ones that were more frail were selected out. There's examples in the literature for both the scarring and the selection. Before I close out this presentation, I need to note two caveats. The first is that I discovered an error in the scale of my mortality estimation, but I had no time to re-record that section. There would be 3.8 million deaths estimated rather than the 5.7 million that I presented. But the broad concepts are still valid. The second more important caveat is concerned with two very recent studies of COVID-19 antibody seroprevalence in California, one by USC in Los Angeles and the other by Stanford University in the Bay Area. Both reported essentially the same result, that the fatality rate of COVID-19 virus may be as low as 0.12 to 0.2%. I'll illustrate the importance of these studies, noting the challenges of estimating fatality rate. You have case fatality rate, which are, as you recall, deaths per detected case. But there's also another metric called infection fatality rate, which is a deaths per detected and undetected case. So you see the iceberg metaphor concept in the lower right. Everything above the surface there would be the detected cases. And so with the those detected cases, you'd have a 10% estimate of the fatality rate. On the other hand, if you could detect what's heretofore been undetected, then you would have a fatality rate of 0.01. We're talking about a 10-fold change. I'd like to close by saying that in light of these new findings, the orders of magnitude differences in country case mortality rates, and in the overall general importance of having accurate actuarial information for COVID-19 policymaking, the preliminary results I presented here should be useful because they show the importance of testing, not only for purposes of social distancing, but as the only way to obtain an accurate estimate of the denominator for the case fatality rate, a parameter of cardinal importance in pandemic policymaking. Thank you.
I have a question here. Thank you, Jimmy. I have a question here for Dr. Cohen or Dr. Cooperman. I have seen the health experts indicate that they expect a second wave in the fall. And another question to Dr. Maverax that says, hand sanitizer only kills bacteria, not virus, right? Would it not be better if you cannot wash your hands to use a wet wipe? A very practical question. So let's start with the first question. Dr. Cohen or Dr. Cooperman, one of you could answer that question.
I think there's potential for recurrence in fall. As Dr. Pan brought up, I think that our social distancing in California has done a great job of flattening the curve. It's also decreased the number of people who are likely to be infected, and therefore the majority of the population will still be susceptible. And if this pops back around in the fall, which it likely will, as most respiratory viruses do, there's at least a chance for it to be for another wave. No guarantees one way or another, but I think the likelihood, I think we have to plan for it, that's for sure.
Let me just add, Stuart, one other thing is that as it resurges in the middle of influenza season next year, that will add extra burden because we started dealing with COVID here towards the end of influenza season this year, but it'll be smack dab with all of influenza next year, complicating our evaluation and treatments.
Dr. Maverick, there for the other question?
I don't think he's on.
Okay,
I think
so-
he had to step out. I can address the question about the wipes. If you want. Yeah. So you know, coronavirus is an envelope virus, and therefore it's actually quite sensitive to both soap as well as to ethanol, so alcohol. So yes, those are good ways to get rid of viruses as well. Probably, as we discussed a lot before, hand washing is preferred, but alcohol is also effective.
And the question is that whether wet wipes would do the job?
Well, wet wipe, I don't know what's in wet wipes, but if it's, I'm not sure whether there's enough alcohol in there, a high enough percentage that it would affect the virus.
Lots of questions about the vaccines. Could you talk about the vaccine now, Nicole?
Yes. Do you want me to share or just
Yeah.
talk?
I'll
Or
stop sharing here and you share from there, please.
Yeah. All right. So I just make it very brief because time is running out. Let me get to the important part, which is that when we look at what is currently in the vaccine pipeline, it's actually quite an amazing number of different vaccines that are considered platforms. And what is really most interesting is that our early vaccine or most of our childhood vaccines, they're all based on either a part of the virus inactivated or an attenuated, well, it's not attenuated, in most cases not attenuated. What is different now, we have realized that we want to have antibodies, but we also want to have the cellular part of the immune response. And for that, just giving that virus is not giving us the type of immune response to activate those cellular immune responses. So these are the ongoing clinical trials that I could find. And there are currently actually 4 I'm showing here. And all of them that I'm showing here are using platforms that would allow both the development of antibodies as well as the induction of cellular immune responses, which is really a huge shift for vaccine development. So the one that, the one that's in, so let me just briefly say that phase 1 clinical trials, which is what all of those ongoing clinical trials are mainly there to test that a vaccine is safe, i.e. that when you give it to a patient, it doesn't cause harm. There is 2 clinical trials that are phase 1 and phase 2. Phase 2 is where you're showing whether the vaccine does what you want it to do, which is in most cases inducing antibodies. And then a phase 3 study would actually show whether when you give to a population of people the vaccine and you have another population that is not vaccinated, are those people more protected when they get the vaccine? So we don't have any phase 3 clinical trials going on right now showing us whether there's actually efficacy. But we have these vaccines in the pipeline. And just to point out the speed with which this occurred, on January 11th, the Chinese scientists revealed the sequence of this new COVID-2. And the sequence was deposited in a public accessible database. And within just over a month, a company that the NIH had been working with to develop a vaccine against the MERS, the very related coronavirus, had developed their platform and basically used the platform that they had developed for coronavirus MERS, and used, instead of the genetic material for MERS, they used the spike protein of the SARS-CoV-2. And on March 26th, the clinical trial was initiated, and it's actually a collaboration between Emory University, the company Moderna, as well as the NIH. And so this is a phenomenal speed with which this is going forward, and really highly promising. And then, as I said, there are 3 others that are slight variations of a very similar principle, which is you provide the body with the genetic material. There will be, the body itself will make the protein of the virus, but it's not infectious because it doesn't have all the other parts of the virus. And then that antigen is then presented and used for the immune system to make antibodies against. All of these, although the details are obviously proprietary, all of these are based on the development of antibodies against the spike protein, and hope to induce neutralizing antibodies, which would prevent the infection from occurring.
Thank you, Nicole. Senator Penn, how do you envision social life at the other end of this pandemic, and how you transition from here to there in terms of social distance and things like that?
Well, first of all, let me just appreciate the discussion about the vaccines. And certainly we may not be ready to have a vaccine in the near future. It'll probably take at least 18 months. But I should mention, we do have a vaccine for this coming fall that we should be thinking about. As Dr. Cooperman mentioned, this virus will come at the same time as the flu. And we do have a vaccine against influenza. And so, unfortunately, the uptake is still only around 40% of the population. We need to find a way to get that up so that if we have coronavirus and the flu, that we actually try to minimize the amount of flu cases we have in the hospital, so we have room for the coronavirus patients. Now, talking about social distancing, I think as I talked about before, what we want to try to do is get to the place where we can test, trace, and then isolate. And that would give us the opportunity to potentially lift some of the social restrictions or physical distancing that we need to do. As I think the governor said, it's not an on and off switch, it's like a dimmer switch. So what we hope to do is, once the number of cases decline, we are going to be able to then, with testing and tracing, be able to identify what we need to have, what the level of infection there is, and be able to start lifting some of the physical distancing. So hopefully, if we are successful and we don't have logistical problems getting our tests done, and we have enough PPE so that testing can continue, that we have the contact tracing with the personnel we hired, we can then start lifting, including, I certainly hope we can try to get kids to start school at the beginning of next school year. But unfortunately, until we get there, we won't know. So the data and the science has to drive these decisions. Ultimately, the final phase is having a vaccine or something or treatment that allows us to manage this infection. Knowing that's going to take time, we are going to have some version of physical distancing, probably, hopefully, not as much as we have now, going into the future. And again, that'll be driven by the data that we are collecting from our testing.
Thank you very much. Another question that came here, pre-submitted, is what's the best fabric to make a mask? How long does the corona live on surface and the package that they are delivered to us? And I would like to know how long the virus lasts on different types of surface. And I heard that you have to wait 24 hours before handling your mail, paper products. Is this accurate? How long does it last on other surface? I did some research on that to see if I could find someone that could answer that question. The only paper that we have in the literature is this paper that appears in the New England Journal of Medicine. And here they compare various surface, and the plastic, for example, shows the very high half-life of that, and compared to cardboard board, also very high, long half-life. So the seems that the virus stick on the surface for a long time, but we cannot find another paper or literature that tells how long it lasts on your newspaper or in your package. There is not specific research on that. I will ask Nicole if she is aware of anything that has done, because the literature in PubMed does not bring anything specifically to that. This is the only study that was made that I could find. Nicole, are you aware of any other things?
I don't know of any other studies, and I think that one question is, can you detect the virus material? The other one is it enough virus material to actually infect? And I would think that the risk from picking up the virus from cardboard or material like this, that somebody may have touched who has had SARS-CoV-2 would be very low, because the amount of virus would probably be really low. That doesn't mean we shouldn't be washing our hands after we touch something and may have been exposed, but I know of people that leave everything they buy for 4 days in the garage. I would not go through those lengths. I don't think that the virus is an envelope virus, and envelope viruses, as I said before, are really quite sensitive to heat, to environmental exposure, to various things. So I think, I find it hard to believe that the virus would live for 4 days on some plastic, or even a day, even 20.
I think you made a really good point, Nicole, that I think has to be re-emphasized. You don't get infected by getting it on your hands unless your hands go somewhere where it shouldn't go. And so you have to carry it from the cardboard or newspaper or whatever that it may live on to your nose or to your eyes or to your mouth. And so by cleaning your hands after touching things, even if there is live virus, and I agree, the likelihood is that it's a small amount, but we know from the first go round with SARS-CoV, that environmental surfaces in hospitals were often high risk, water fountains, other kinds of things, but that was because people were getting it right up into their respiratory tract, not getting it on their hands.
Dr. Cohen, there is another question here. I think it's an entirely different situation, because what if a person has a wound, a cut on the hand or something? Then that's a door there, right? Or not?
Yeah, I guess it's possible, but it seems unlikely to me too. Right? The target receptors, I don't know if they exist on skin. Do you know, Nicole?
Sorry, I'm pretty sure they do not. It's epithelial cells of the mucosal surfaces. So yeah, the receptor through the skin and a wound or something is very unlikely. Yep.
Right.
Yeah, I had a hand surgery at the beginning of the crisis, and I never had a problem. So I assume that is right. Dr. Cohen, there is another question regarding ACE, the receptor, and is that the patient that has a pre-existing condition, like, for example, if they have diabetes, is that true that these receptors are expressed in larger quantities in this kind of patient? That's why they are more prone to get infected?
Again, I can't address that. What I can say is this. Those receptors are targets for antihypertensive medications. And there's some suggestion that people are on those antihypertensive medications do worse. There are some suggestions that they do better. There's actually a clinical trial that's being done with an antihypertensive to treat SARS-CoV, not one that we are particularly interested in participating in. But I think that I think that's more associated with hypertensives than it is with diabetes, unless Dr. Baumgarth knows something different.
No, I would agree. I think it's less about whether the ACE2 receptor is expressed. It's more whether its function is affected. And as Dr. Cohen said, that people with diabetes or hypertension, their balance of this of that protein that regulates blood pressure is already tilted towards reduced function of the ACE2, and the virus seems to exaggerate that, and that leads to more inflammation and so on. So it's really more to do with the outcome, because as we have discussed all afternoon, getting the virus infection is not so much the problem, it's getting the very serious consequences of having the virus infection, which in part has to do with the immune system being overstimulated, in part to do with this the blood pressure and all the vascular system being out of whack. So it's really probably not to do with how much of the receptor is there.
Dr. Cohen, the question regarding the problems with hydrochloroquine combined with amoxicillin and azithromycin, some patients having heart problems with QT being very long or something like that. Do you have any word on that?
Yes. So I'm going to say this, and this will be my last comment because I've got another meeting that I have to go to. So hydroxychloroquine and azithromycin both prolong what's called the QT interval. And that's a resting phase as the electrical cycle goes through the heart. And if the QT gets too long, then the electrical cycles can sort of pile up on top of each other, and people get these heart arrhythmias, which is called torsade de pointe, or probably pronounced differently if you can speak French, and that can lead to ventricular fibrillation, which can lead to death. So people who have underlying heart disease that already may have some compromise in the electrical system of the heart, that can be amplified by giving people these medications that already cause it, even in people who have normal heart function. So it's really dicey, since one of the high risk groups for bad outcomes are people with underlying heart disease. I think you have to be very careful using hydroxychloroquine, and particularly in combination with azithro. And I think most guidelines say that all these drugs should be used in the context of a clinical trial to determine whether they actually do anything or not.
Thank you very much for staying about the time that you are going. So a question about the masks, I asked a specialist from UC Davis, a distinguished Professor Yu Lo Hichi. She's a specialist in textiles and clothing, and she explained how these masks are made.
For the medical professionals, the most common masks are the surgical mask and the N95 mask. Both type of masks are typically made out of hydrophobic polypropylene nonwovens. The typical structure is 3 layers. The external internal layers are spun-bonded polypropylene. The middle layer is the active layer. There are fine melt-blown polypropylene fibers, and they are usually charged in some way so that to attract the smart particulates. Surgical masks, and both surgical masks and N95 are meant to prevent transfers of particulates and microbes, although for different reasons. Surgical mask is to protect the wound from breath of the surgical staff and nursing staffs, whereas N95 is meant to protect the wearer from the particulates in the environment. So the main difference is whether the particulate transfer is from wearer to the outside or from the outside to the wearer.
So for the public in general, they don't need to have an N95 mask. And the recommendation that people say is that if someone is sick, having problem of breathing, that they should use a N95 mask to prevent infect other people. But if they already have a problem breathing, probably they are not going to be able to wear a N95, because you need really to be strong, your lungs, to breathe through that. Is that right?
Right. The N95 has many, many layers of fibers, and they're meant to fit around the face of the person, above the nose and around the face. So it's supposed to pretty much seal between the mask and the face to allow the airflow only through the membrane material, so not around the leak. Because of that, actually the flow rate is slow. So for people who may have difficulty breathing, this can be make it more difficult. Surgical masks don't fit as tightly around the face, and also the materials are thinner. So it allows easier breathing, and also it will not impede breathing as much. But as a consequence, the protection is not as high. For, of course, the N95, the designation is it blocks 95% of particulates that less than 0.3 microns. So it blocks a very high proportion of small particulates, submicron particulates.
So when the public cannot find masks available to buy, they start to improvise. And by improvise, they can do good things, but they can do also some harm to them. Can you explain to the public what kind of things, if they are doing, they may be causing more harm than good?
Well, I think no matter what kind of materials we access from our home or some other industrial filtration material, I think there are several things to consider. One is that for anything that are made for a pump or instrument like a vacuum cleaner, for car, for house, is meant for a machine-driven airflow. So usually they don't have the kind of diffusive property, the permeability as the breathing mask. So that is number one. Number two is the kind of material they use may not be suitable for breathing into our system. They may contain glass fibers or binders or other materials that are meant to trap the particulates, but may be harmful for our respiratory system. In terms of common materials, household material, one will be looking at something maybe not too porous. So if you see a gauze material, you can tell, you can see through, you can see a lot of hole. We know definitely they're too large, because the airborne particulates that we're talking about, droplets that come from our breath or talking or sneezing, they're tens of micron size. They're usually small enough to pass through most fabrics. So we want to have something tighter, woven together, so not a loose kind of material. But then we know if we have very tight material, it'll be hard to breathe. So there's a trade-off between how much you block and how much you allow yourself to breathe. So usually we're looking at tighter woven material like cotton material, sheeting material. They're common, people can find in their house. Those are usually a good place to start, mainly because they're natural and they don't have any finish. I would caution people to use any kind of easy care kind of fabric, which means that they have permanent press, that chemical finishes on, and those are quite a few percent of those added chemicals. They can fragment and get into our breathing system. So natural material, usually good, tighter woven material with smaller pores, but make sure that one can breathe easily through.
Thank you. Do you have anything else that you'd like to add?
I would, I think there's a lot of unknown still. So I would think just look at the ingredients and make sure that the material is not used for industrial applications, because that usually doesn't have the kind of rigor that used for consumer products. So I think that probably is a good place to start.
Thank you very much. Dr. Senator Pan, there is a question regarding how to reconcile the different constituents in the state of California when we have people that really want the economy to open up, and there is a majority of people that they trust that the best course of action is to stay sheltered in. So how do you, as a now not a medical doctor now, but as a politician, how do you reconcile these two different factions?
So first of all, I point out that if you truly want the economy to come back, then you need to stay at home. So we look at the data we have from history, we look at other pandemics and see what has happened. So economists have looked at what happened in the 1918 influenza pandemic. They noted that the cities that did stay at home earlier and persisted in doing it until they got control over the disease, not only had fewer deaths, which is the public health outcome we like to see, also had economies that returned back to normal faster. So if we really want to try to get back to our economy starting up, then what we need to do is continue to have the resolve to wait until we actually get control over this virus. What that means is that not only, of course, do we stay at home until we have a declining number, we ramp up testing, we ramp up contact tracing, we isolate people who have the disease. I would make note that people will not go out to restaurants, to movie theaters, to other types of places if they're afraid they might die. And if we just open it up too early, we will have not only a rapid rise in cases, we will have a rapid rise in people being hospitalized and people dying. You think about what happened in New York, and people will be afraid to go out. The vast majority of people will be afraid to go out. So if you run a business, you're not going to have customers, right? That's going to be a problem. I'm a small business owner. I understand this. So let's work together. We need to work together. We need to get control over this infection, and then we will be able to bring back our economy. Now, I'll point out that until we have a vaccine or effective treatment, we're not going to go back to what we had before. So people are going to have to make adjustments to their businesses. There are going to be adjustments that are going to have to be made to different types of jobs because of that. And our essential workers certainly know this because they're still working. So we have a lot of work to do, and that's what we're going to focus on. But we have to understand that it's not a choice between lifting the economy and staying at home. It's actually doing both achieves the same aim.
Thank you. A question here is that will we have another pandemic? How should we get prepared to avoid another pandemic? And what lessons should we learn from these and previous pandemics to avoid another one in the future? So I ask again the historian and immunologist, Michael Oldstone.
So what is your perspective on that?
Well, I think I think it's absolutely certain that other endemics and pandemics will occur. What's happening is that our species, Homo sapiens, are encroaching on other lands where there are lots of animals, and most of these infections are related for passing from an animal to a human. And if they pass from an animal to a human, and the passage from human to human is low, then you can control it as locally. But if it goes from an animal to a human, and then human to human spreads rather rapidly, then you have a lot of big trouble. So, for example, when you had a flu before, and the hemagglutinin was called H5, it came from a bird, the mortality rate was extraordinarily high, 30 to 40%. And many people thought this would be the next exactly flu pandemic. And though it passed to humans, the passage from humans to humans was not very good. And that allowed it to be curtailed. Now, what I think has to be done is we have to follow sort of the influenza system. Because the influenza pandemic, we now have surveillance areas all around the world. So as new influenzas arrive, they're rapidly seen, isolated, they're then classified, they determine the type of influenza that's there, and then people can develop tests for them and vaccines if needed. It's a problem biotechnically in getting the vaccine out quick enough. We don't have a universal vaccine, so there's a problem there. But we need the same type of thing. We need a surveillance system that's done in multiple countries. most of these infections are occurring now through Asia, mostly through China, because of the open markets that are present, and the large population that it becomes exposed. And then they're spread rapidly because of rapid communication. So you can be infected, incubate a new agent, travel to Europe or the United States, as happened here, and then completely spread the infection. So I think that we need surveillance systems, number one. Number two, we need to have a better coordination. For example, I can speak about the United States in our country. So there's a group that's able to coordinate, that sort of a czar of this type of public health and medicine, that if something breaks out, they can have response to the politicians who must carry this out about what's going on, and security, and we have to have stockpiles of medicines, of ventilators, of masks, of equipment. All those things have to be stockpiled. Generally what happens is that you have an event that occurs, let's say Ebola occurs, everybody gets very excited, they do a lot of things, Ebola then disappears, and the interest disappears. The government no longer funds, or funds very poorly, Ebola research or Ebola taken care of, and then something else happens. So we need a more centralized area that contains people in our biotech group, in our science group, in epidemiology, in security country, and some and people politically who are in a overall committee that can handle these things as soon as they've broken out, and advise the president and whoever's responsible for acting quickly for what happens. So our intelligence and surveillance network has to be better. And when we will look back at what's happened with COVID-19, we'll find out how poorly we were prepared. We'll also, look, I served on the WHO panel for the eradication of measles and polio. I also was on their executive board. I think the WHO, what it wants to do is great. There's no question that it's very political, and there's no question that it wastes a lot of funds. But we have to strengthen WHO so it becomes less political, more open, and is able to do a better job than it has done. And we have to make sure that the United States has its own security and has its own operation in place in cooperation with other countries for the screening that I'm talking about.
I guess that's better to waste a lot of money than to waste a lot of life.
Well, it will be expensive. Yeah, it will be expensive. But if you compare the expense of doing that, compare the expense of shutting down the economy and what we're doing now, it's pennies to multiple dollars, isn't it?
That's true. Do you have anything else that you'd like to tell at the end that I didn't ask?
No, I don't think so. But I think the more communication we get, the better. You know, there are always going to be a bunch of people who you can't convince of anything. In fact, I'd like to read to you a quotation that I wrote down, which I really, really like. But it says a lot. It's by Mark Twain. And it says, "The trouble with the world is not that people know so little, is that they know so many things that aren't so." So that's what I'd like to end with. And the fact that history does repeat itself, and that all the things we've seen with these pandemics and endemics that have devastated populations and people, we've been able to come through with them, build on them, and become stronger. We have to realize that we need to put preventive things in care so that we don't get caught with our pants down again.
Again, thank you very much for your participation.
All right, so thank you, thank you all the panelists and all the people who contributed to this presentation today. Thank you, Nicole, for staying up to the end. Senator Penn also is there. There's a last question here that A.G. Reed asks the panel. That I'm going to summarize the question, but he's saying that he gets conflicting information. From one hand, we see bad news, and from the White House, always the briefing gives good news. And where should I go to get information that's accurate? I think that's all of us are struggling with that, but maybe the senator can address that issue.
Well, what I'd say is, you know what they said about climate change? Listen to the scientists. I would say the same thing. The scientists and the physicians who are knowledgeable should be speaking, should be the main spokespeople. The other thing I should also point out, though, is that this is a new virus. We heard that from many of the other panelists. So what we are learning about this does change over time. So to expect that someone was completely, quote, consistent from, let's say, February to now is not the test of their veracity. I think what's most important is that they have a knowledge base and that they are analyzing the data, and that what we need to do is, again, listen to the scientists collectively. So the more people are working with each other, and there are things that are going to change and we don't know. But that's who we should be paying attention to the CDC, to the World Health Organization, to the California Department of Public Health. These are the people who are trying to coalesce this information. And so I really want to thank you for doing this panel, because we've been able to bring in people with that knowledge to try to share accurate information. We may learn things that will change some of the things we talked about today in the future. That's okay. But it is important that don't just go and retweet something that sounds really cool on your Facebook feed, your Twitter feed. Be sure it's from an accurate, good source. And we have a lot of misinformation. The World Health Organization talked about an infodemic. We have a problem there. I would say, again, thank you for this panel. Listen to the scientists, listen to the doctors who are taking care, who are invested in taking care of this condition.
Thank you very much. Nicole, do you have any other closing comments in general, not specifically to that question?
No, I think that I don't have really anything to say, and I would echo the listen to the scientists. Of course, I'm a little biased, but I think it's very important that we share the information. And it's sad when there is a feeling out that something is politicized that really is just for instead of really looking just out for the patients. So thank you, and thank you, Walter, for spearheading this. I think it was very informative. And
thank you. Dr. Maverax, before the closing, can you address the question that was before you were not there?
I was on another conference.
I know we are all multitasking, right?
What is the question?
Yeah, the question basically was that, well, if the hand sanitizer only kills bacteria and not the virus, would not be better to use wet wipes?
So
didn't have an answer for that question. So
the hand sanitizer does kill bacteria. I want to emphasize, I mean, it does kill virus. There has been studies showing that the hand sanitizer does kill virus. Now, I definitely don't want people coming out of this saying that hand washing is bad. I just think that we need to have a combined strategy where we are maximizing the feasibility, the tolerability, and the frequency of engaging in good hand hygiene. So if you cannot wash your hands because you don't want to go in through, this public bathroom, or if your hands, if you're one of those 15-20% of the general population that has a significant barrier defect, and you just can't scrub your hands for 20 seconds 10 times a day, it's literally impossible for most people to do that. Then I believe that you should do hand washing to tolerance, meaning that you wash your hands when possible. and how much you could do a day, and you would know that, like, you could wash them 5 times a day and your hands could tolerate that. So you should keep that for when you've touched something that you think is contaminated or when your hands are soiled. Then use hand sanitizer to augment the hand washing therapy. It's not like one or the other, which is the current CDC guidelines. They say, only do hand sanitizer when soap and water is not available. So then to answer your question in terms of the wipes, so the wipes are a little bit problematic. Now, I agree that the wipes might be able to get the, it depends on what kind of wipe, but in general, like a Clorox wipe or something like that, they might be very good at killing the virus on your hand. So I don't disagree with that whatsoever. But again, what we're looking at here is something called tolerability. So your hands cannot handle alcohol sprays. They can handle moisturizing alcohol hand sanitizer, which has glycerol in it. But hand disinfecting wipes, like Clorox wipes and all that, those could be extremely harsh on your hands. They're not made, their product's not made for hand cleansing. So I don't recommend that. If you have some kind of, superhuman hands and you could tolerate them, maybe, but I would say the vast majority of Americans would not be able to tolerate using wipes, disinfectant wipes multiple times on their hands a day. Is just gonna beat up that skin barrier. Again, I wanna emphasize that the skin barrier was not made for all of this hand sanitization. So we have to, tailor the regimen to you. You might have great skin barrier. You might be able to wash your hands a lot of times a day, and you might have easy access to soap and water. So great, go to it. But to answer the question, no, I don't recommend hand sanitizing wipes. If you have a different experience with them, then that might be okay. But I as a physician, I don't see that that's going to work.
Thank you very much. Any closing remarks? We are closing now. We are only 1 hour and 10 minutes behind the schedule. So thank you very much. Thank you all the panelists. Thank you all the contributors to this symposium. And particularly thank you to all of you that keep watching it up to the end, although we went over 1 hour and 10 minutes. Thank you, and stay well.
Thank you, Walter. Bye.
Bye-bye.
Thank you.